teaching program for postgraduates in pathology. The chairperson for today's talk would be Dr. Amita Maheshwari, Professor and Head Division of Gynecologic Oncology, Tata Memorial Hospital, Mumbai. Today's slide seminar would be on cervical cytology, case-based learning, and the presenter would be Dr. Kamal Meherbano, Madam. She's the ex-professor and the head of department, Government Medical College, Nagpur. The participants for today's sessions would be, these are our students. I'll ask them to introduce themselves one by one. Dr. Shehnaz.
Hello everyone, myself Dr. Shahnaz, third year postgraduate from BLD Bijapur.
I'm Dr. Chinmay. I'm third year PG resident from Armed Forces Medical College, Pune.
Good evening, everyone. Myself, Dr. Deepmala Karande, third year PG resident from GMC, Aurangabad.
Good evening, everyone. I am Dr. Shilpa from GMC Jammu. I am third year PG resident.
Good evening, everyone. I'm Dr. Aparna, third year postgraduate resident from Gopala Medical College, Kerala.
Nupur. I think okay, we'll go to Nupur is maybe not. We can go to next slide, yeah.
The moderators for today's talk would be Dr. Janvi Gandhi. She's the Assistant Professor, Department of Oncopathology, GCRI, and I myself, Dr. Shaili Mehta, Assistant Professor, Department of Oncopathology, GCRI. Webinar hosts are Dr. Anita Borges and Dr. Sumit Gujral, sir. Here are a few reminders. And these are a few disclaimers. The digitized slides are proprietary property of the presenter, and any unauthorized reproduction of the same is strictly prohibited. Upcoming talks would be on 17th of January, we have a lecture on artifacts in histopathology by Dr. Praveen Mahajan. Sir is a consultant histopathologist at SL Raheja Hospital, Mumbai. And on 19th of January, we have a slide seminar on endometrial neoplasms by Dr. Kedar Devdhar and Dr. Divya Mida, ma'am. Dr. Kedar sir works at TMS Mumbai, and Dr. Divya Mida is a consultant histopathologist at TMC Kolkata. Let's start. Over to you, ma'am.
Yeah. Thank you, Shelly and Janvi, for that kind introduction. And also, I would like to thank abundantly to Dr. Sumit Gujral and Bojes Madam for giving me this opportunity to interact with the postgraduate students present here. And it's always a pleasure to teach them. I hope I do justice to the subject. The subject is vast, and we'll try to curtail many things, and maybe we can do more detailed teaching at other times. Now, another thing that I would like to say that I hope you people are aware that month of January is a cancer cervix awareness month. And if Sumit, you have done these lectures like the talk on HPV by Dr. Radhika and cervical cytology by me, with the knowledge of this, hats off to you for keeping so much information. And if not, that's also a very fine thing, so that these talks are falling on in the same month as the month of cervical cancer awareness and prevention. So let's start. I will be giving a small introductory talk, and after that we will pursue our cases. Everybody, I hope you can see the screen.
Yes.
Yes, ma'am.
Now, who's this great man? You all know
George
he's
Papanicolaou.
Yeah. So Dr. George Nicholas Papanicolaou, what is the name of his wife who's standing behind him? Andrew Mahi Mavrogeni. So this scientist couple was responsible for giving birth to cytopathology as the subspecialty of pathology. They got their untiring efforts in this field have brought them a lot of awards and accolades, but the highest honor came in when the scientific community at large decided that cervico-vaginal cytology would be named as the pap smear. That was the best thing that could have happened to remember him. Now, with the revolutionary discovery of the pap smear, a massive cytology screening program was launched in Jefferson County in 1956. It was a model program and it lasted for 16 long years. And when the statistics of this program showed that the death rate due to cancer cervix has dropped from 25 to 10 per lakh women, the WHO announced that cancer cervix is preventable. Now, preventable but not yet prevented is the reality today. You saw this same graph when Radhika madam projected, and you know the incidences are variable, but they are pretty high in the Asian continent and the African continent. And in India, they say that every 5 minutes a woman dies of cervical cancer. You also know that this is caused by which virus?
HPV, human
Papilloma.
papilloma virus.
Yes, human papilloma. It's a huge family. More than 200 viruses have been discovered. Some of them are high-risk viruses. Rest of them, and these viruses, they have affinity. The high-risk viruses, particularly, and some of the low-risk viruses, they have affinity for the skin in and around the genitalia, and that is why we get those infections in this area. And these are responsible for three types of diseases: that warts, the dysplasia or the precancers, and invasive cancers. Now, what about the pathogenesis? It's very clear, and with the understanding, as we are understanding more and more about the pathogenesis of cervical cancer, now we know that there are two major categories according to the Bethesda system: the low-grade cells and the high-grade cells. Now, Chinmay, can you tell me what happens in low-grade cells quickly and in the high-grade cell?
In low-grade cell, it was previously called as the CIN1, cervical intraepithelial neoplasia 1, and HCL is the SIN2 and SIN3. The moderate and severe dysplasias are categorized into HCLs.
Yes, no, but you haven't told me what is the episomal growth and what is the integration of the virus into the host genome. That's the major difference. So the low-grade lesions are just productive
Episomal.
lesions. Pardon? Low-grade lesions are just productive lesions where the viral particles, they are multiplying within the cytoplasm of the mature squamous cells using the machinery of the cytoplasm, and then they break up there, they multiply, they assemble again, all the proteins, they assemble back again. I'm showing you a picture over here. And then all these viral particles, they are shed out. But in case of the high-grade lesions, and which is particularly caused by which viruses, you name them in one breath.
16, 18, 6, 8, 16, 18.
Yeah. Now what happens here? There is integration of the HPV DNA into the host chromosome, deregulated expression of the HPV E6 and E7, and interactions with the cellular regulatory proteins, and there is disruption of the cell cycle, integration of the virus into the host genome, which transform them into the immortal cells, and then here you directly get a high-grade lesion. So high-grade lesions, remember, they can arise de novo. They do not have to go through the phases of CIN1, CIN2, CIN3, which was our previous understanding. There is a subset of high-grade lesions which are arising de novo. And what is the difference? How do you know these have come from de novo lesions and these have come from the long-standing lesions? Any differences clinically? These women in whom it arises de novo, they are generally younger women, and the lesion develops within 1 or 2 years of the infection. And women who are developing it over a period of 10 to 15 years, they generally are of 55 to 60 years of age. But these you can find in women as young as 20s, in their late 20s and early 30s. Now the Bethesda system, how many classifications of Bethesda system have come up till now?
3 classifications.
Okay, you can just add one more. There have been 4 revisions of that. But basically,
2016.
no, the first one was in
1988.
19.
Yes, second one was in
1991.
91, then
yes,
2001
then
and
2014.
2014.
yes, perfectly correct. Now the Bethesda system has made it very loud and clear that a pap smear report is an interpretation of all the findings that you are seeing, and it does not, it contributes to a diagnosis, but it itself is not a diagnosis. So previously, in the previous classifications, they used to call it, the category was diagnosis. What is our diagnosis? But this was stopped because they were also using terms like CIN1, 2, and 3, and mild dysplasia, moderate dysplasia for histopathologic tissue. So when it was used in cytology also, it was mistaken as if cytologic diagnosis is a final diagnosis. So, and that started having caused a lot of problems to the clinicians in the management of the patient because it was not truly correct. So then it came, the revisions of the classification made it very clear that the cytology report is an interpretation and does it contributes to a diagnosis, and it brought the world together with one cytologic voice. Now this is the standardized reporting framework. Now, Deepmala, I think Deepmala is a little. Shahnaz, can you read out quickly the 5 categories that you are seeing, the main headings?
Yes, ma'am. Specimen type, specimen adequacy, general categorization, interpretation or result, and notes.
Yes, so we will be going into each of these categories as we move with our cases, and each case I will tell you how you are going to report it, and you'll have to tell me in what are the words that you are going to put in under each category as we move. So we'll not talk much on this over here. You all know what is the transformation zone, what is the squamocolumnar junction. Now in this picture you can see the pink endocervical mucosa, and the pale squamous mucosa, and this junction is the squamocolumnar junction. And what is the transformation zone, Shahnaz?
Ma'am, transformation zone is the space between the old squamocolumnar junction and the newly formed squamocolumnar junction after the metaplasia has happened.
And what keeps changing, the squamocolumnar junction or the transformation zone?
Squamocolumnar junction keeps changing, ma'am.
Yes, and so the TZ also.
Yes, ma'am.
Now, if you understand, this is because of multiple causes like a change in the pH environment of the vagina, multiple deliveries, infections. There is ectopy, that is eversion of the endocervical mucosa onto the portio of the cervix, and the squamocolumnar junction starts moving outside onto the portio of the cervix. But ultimately, this has to heal. So there are 2 methods of healing. Have you heard of ascending repair and descending repair? When the squamous epithelium from the portio starts replacing the glandular, healing the glandular epithelium, that is known as the ascending repair. And when the reserve cells that are present beneath the endocervical epithelium start changing, and they become metaplastic and form a squamous epithelium, that is known as the descending repair. And then you get these islands of cells. These are the metaplastic islands, and then ultimately the whole glandular area is replaced by mature squamous epithelium. And then in the end stage, you are not able to identify whether this epithelium is a mature squamous epithelium which has come, this mature epithelium has come from immature metaplasia, which has undergone in that glandular area, or it was the original epithelium which was present in the onto the portia of the cervix. But in histopathology, you can identify, not clinically. In histopathology, you can identify because glands are present beneath the squamous epithelium. It's okay? Now, a cervical smear adequately collected from the squamocolumnar junction and the transformation zone, well fixed and well stained, it's still a very simple, economical, and convenient method for detection of the crime committed by the culprit virus. Now, there are a number of devices that are available. What are these called as? Just name them
These
fast.
are endocervical brushes, ma'am, and
This is
air
the brush.
spatula is also shown here, ma'am.
Yes, this is the iris spatula. What are these? One of them is inside the canal. These are known as the Zale spatulas. These are plastic spatulas. This is a wooden spatula. This is a brush, and this is just a cotton tipped applicator. So a variety of devices have come so that we can precisely sample the transformation zone and the squamocolumnar junction. Now, no matter how nicely designed is the collection device, it is always impossible to standardize the application of the material that you have collected from the transformation zone and the squamocolumnar junction onto the slide. And as a result of this, in a conventional pap smear, you have uneven distribution of cells, thick and thin areas, and there is a lot of inflammation, mucus, and blood that comes along with the spatula. And in the hurry and worry of doing immediate fixation. Now, what do you understand by immediate fixation? Immediate wet fixation, that is the term that we use.
Ma'am,
Immediately
immediately
putting
putting
the
in
slides into the pap fix, ma'am.
So, what is immediate?
before drying of the smear, ma'am.
Yes, while it is still wet, you have to put it in the alcohol. What is the concentration of the alcohol?
95% ethyl alcohol, ma'am.
Ethyl alcohol. So sometimes in that hurry and worry, you try to spill the costly alcohol, and what in the end you get is air drying artifacts on the slide. And that is why it is said that sometimes searching for abnormal cells is like searching for a needle in the haystack, because there are so many components that are present in the slide. So now to our rescue, we have got the liquid based preparations that are coming up. You have a cervix brush over here which snugly fits the endocervical canal and collects the cells from the transformation zone and the squamocolumnar junction. You have to, how many times you have to rotate the brush?
5 times, ma'am.
5 times. And I will just highlight, tell you emphatically that the rotation has to be very gentle and with slight pressure, and you do not scrape the cells deliberately, because this branch is called part of exfoliative cytology. The cells that have been already exfoliated onto the surface of the cervix, that we collect and we study. But if you try to deliberately scrape them, then you are going to get false information from the material that you have collected. And I know that all this information is relevant to the gynecologist who's collecting the smear, but we also should know so that we can tell them when we see such scrapes and deep artifacts in the slide. And I'm telling you this because I collect the pap smears myself, and I also do the colposcopy. Now, after you have collected, the next step is what? You break the head of the brush. You all must have seen these pictures on the net, and in your seminars you must have prepared these talks and label the vial and send it to the laboratory. What is the biggest advantage? Tell me first two advantages of this vial. What does it contain?
Fixative, ma'am. Fixative solution.
Which fixative? What is the concentration of the fixative? Is it dilute or is it as concentrated as the jar you saw? It's a very dilute fixative. 50%. Methanol, ethanol. Now you can see on the vial it's Shopath. Shopath uses ethanol. Okay. And what is the other advantage of the vial? So you're prefixing
All
the cells.
contents are transferred into the BD vial as compared to the conventional smear.
Okay, cell harvesting is there. The cells can remain in the vial as they are, as fresh for a month if it is kept out of the refrigerator, and even up to 6 months if it is kept in the refrigerator. So you have the sample with you, nicely preserved sample with you for this longer time. And the biggest advantage, the third and the most important advantage, whenever you want, you can go in for reflex HPV DNA testing. So if you feel there are abnormal cells, or you have cells like LSIL or ASCUS, ASCH, and if you feel that you need to do HPV DNA testing, the same vial can be used. You don't have to call the patient all over again to take a second sample. Okay. So collect, drop and send with 3 advantages, 3 steps and 3 advantages. That is what you have to remember. Now what happens in the laboratory? There is cell enrichment is done using the density gradient reagent. What is this DG reagent? What happens with this reagent? I thought you all have read about liquid-based preparations and the processing of Shopath, which is now there in many centers. I leave that for you to read, okay? Then a very nice clean cell pellet is formed with the help of the DG reagent. And then this is, there are settling chambers on top of cationically charged glass slides. And there are different types of setup that we have. You can process 2 samples, 4 samples, and in this station, this is a fully automated station where you can process 48 samples at a go. And even the staining is fully automated. Now the difference is very stark. Here you can see this is a conventional smear with so much of cellular overlap, and this is a small diameter. What is the diameter in SurePath?
13 millimeter, ma'am, in SurePath.
Yes, it is 13 millimeter diameter. And how much is the diameter in ThinPrep?
Ma'am, 20 millimeters, ma'am, 20.
Yeah, so here you have a slide of ThinPrep where you have a 20 millimeter diameter where the cells are spread in a monolayer. Now, is there something which is better than the other? Anything you have read? And what is the principle of ThinPrep? You didn't read the procedures?
The obscuring artifacts are better hidden in the SurePath as compared to ThinPrep, ma'am.
Okay, and which is more monolayer?
ThinPrep.
ThinPrep is monolayer. You
ThinPrep,
have
ma'am.
very nice single cell distribution. Why?
Because of
What
the
is
area of
the
distribution of
Diameter.
cells is more as compared to BD SurePath, ma'am.
No, is it using any membrane filtration? It is based on the principle of suction of the cells
Suction.
onto a
Yes, ma'am.
membrane, and then that membrane is transferred onto the glass slide, and then it is stained, it's dissolved, and it is stained. Whereas here, the cells are settling on their own onto the slide. So there is slight overlap of cells in SurePath, but there is no overlap because each pore of the filter membrane, there is one cell sitting there. So there is equidistance amongst each of the cells, and it is a monolayer preparation. Now we'll go to our first case. I think this basic information, with this, I think we should go to the first case. Now, you have seen the cases, you have seen the slides,
Yes,
all of
ma'am.
you? Yeah. So, Shilpa, you'll be with me for this case. Are you okay?
Yes, ma'am.
Come on, read the history.
53 years old woman complains of irregular menstrual cycles.
Now, what do you think are the causes of irregular menstrual cycles at this stage?
Ma'am, it's important is it is a perimenopausal age group, and the most important cause is this. Then there are the fibroids, uterine fibroids are there, cervical lesions are there, endometrial.
What do you understand by irregular menstrual cycles?
Ma'am, having a cycle of more than 34 days, or irregularity in the.
So, right over here, you should know that the LMP is not constant. It is variable. The duration of bleeding is also variable, and this generally happens in dysfunctional uterine bleeding. Broadly, we will just keep it as dysfunctional uterine bleeding as the main cause, and the cause for this DUB commonly at this age is the perimenopausal age group when they are trying to settle down with the menopause. Now, what are these cells?
Ma'am, these are the superficial and the intermediate squamous cells. Ma'am,
Just somebody has opened the annotation request. Okay. So,
Please ignore it. Dr. Kamal, please ignore the annotation request.
yeah, I have closed that window.
Thank you.
Now, the ones which are having a slight orangish cytoplasm, what are those cells?
ma'am, these are superficial squamous cells. These are polygonal, well defined, and measuring 45 to 50 micron meter with pyknotic nucleus measuring 5 to 6 microns. And the other ones are the intermediate squamous cells measuring 35 to 40 micrometer with nucleus slightly larger than the superficial squamous cells, that is up to 7 to 8 micrometer.
Okay, very well said about all the dimensions so that I don't have to go into those details. But I'm slightly interested here in knowing why this color. They should have been eosinophilic, isn't it? They are
Yes.
keratinized cells. They should be pink cells, superficial cells. Here you are having them as orange colored. So what takes up an orange stain?
Ma'am, keratinization.
Not exactly. It will take, of course, orange color, but this is not that dense keratinization.
Ma'am, maybe these are because of ma'am parakeratotic.
Pardon? No. See, these are glycogen filled cells, and glycogen takes a golden orangish color. Now sometimes the colors are cannot, they keep varying because of different pH that each laboratory has, the different staining patterns they have, and the timings each laboratory uses. So what here I want to highlight are these intermediate squamous cells, and of course some of the superficial squamous cells. They are still showing that golden color and they are laden with glycogen. But basically you get glycogen in which type of cell? Intermediate squamous cells. Yes. What is the other component? What are these? Something you can see,
Ma'am, these are
bacteria type.
lactobacilli.
So this is the lactobacillary flora. Is it normal?
Normal flora of
Yes. What is the function of these lactobacilli?
ma'am, to maintain the pH.
How they maintain the pH? How they maintain the pH? The glycogen which is present in the intermediate cells undergoes lysis because of these bacteria, and that is how the pH is maintained. What is the normal pH of the vagina?
Ma'am, it's 6.9.
It is acidic or alkaline?
Ma'am, it is acidic.
It is acidic. So it's up to 6, 4 to 5 to 6. That is the pH. Now what are these cells? Here you had a mixture of cells. Now these are very clear cut. What are these?
Ma'am, these are again superficial and intermediate cells.
No, I'm pointing out to one cell.
Ma'am, this is the intermediate squamous.
Intermediate squamous cell. What has happened to the margin of this cell?
And this folding of cytoplasm.
So what are these cells known as?
Metaplastics.
No, no. And how see the
Navicular cells.
Navicular cells.
Oh, sorry.
navicular
cells.
shaped cells. And they are particularly found in which
Pregnancy.
Pregnancy.
In pregnancy.
pregnancy. And why they become navicular like?
Because of
And
glycogen.
which hormone is affecting them?
Progesterone.
Because of progesterone.
Yes. So long-term progesteronic stimulation will give rise to glycogen-laden cells, and when abundant glycogen is collecting inside them, they try to accommodate that much glycogen, and their margins they get folded, and you have such navicular cells. Now another
Kamal,
feature.
Dr.
Yeah.
Kamal, can you use the laser pointer, please? Students want that.
Okay. Yeah, right. Now, what is the other feature that you are seeing here? Are these cells distributed in a single or a less? This is a conventional smear, isn't it? It's
Yes,
not
ma'am.
yeah. So when I'm showing you the PPT, I have a mixture of pictures from conventional as well as the LBC. So this is a conventional smear. So there is a lot of overlapping and crowding of these cells. When does this happen? It's very typical of perimenopause. So what is also it is called as crowded
Groups.
menopause.
Cell in,
Pardon?
sorry, crowded cell groups.
Yeah. Now, what are you seeing this? I had given you a little homework when we were doing trial. What are you seeing inside the cytoplasm?
Ma'am, these are the keratohyalin granules.
Yes. And which cells are these? Again, so whenever we are talking about the type of cells, you need to say predominantly intermediate squamous cells are seen and few of them are superficial. So this is a superficial cell. This has a larger nucleus. And what is the color of the cytoplasm? Of course, again, as I said, it will vary.
From orange to greenish.
So the color of cytoplasm of intermediate cells is known as, in technical terms, cyanophilic, both blue-green. When it for the superficial cells, what is the color?
Eosinophilic.
Eosinophilic or pink. What is the nucleus of the superficial cells? It's dense, pycnotic, very tiny. So every time you're not going to measure it, but you have to remember for intermediate squamous cells, you have to have a very clear idea about the size of the nucleus, because it is a benchmark for all these squamous intraepithelial lesion. You're going to compare the size of the abnormal cells with the size of the normal intermediate cell nucleus. So what is the size of a normal intermediate cell nucleus?
Ma'am, 35 to 40 microns with the size, it is the size of the intermediate cell with the 7 to 8 micron of nucleus.
Almost of the size of an RBC.
RBC.
So that you have to keep in mind. Now, here you're seeing lot of bacteria again, lactobacilli. Here you can see some of the long lactobacilli. And here, can you see what has happened to the cytoplasm? And you're seeing some bodies over here.
Candida.
These are the candida bodies. Okay. Now what has happened to the cytoplasm over here? It is disintegrating. You cannot see the cell boundaries sharply in all of them. So what is this? What is the term used when the cells are breaking down?
Cytolysis, ma'am.
Cytolysis. And when does this happen?
In the late luteal phases, ma'am, when
Yes,
the
second half of the
intermediate cells
cycle.
start disintegrating.
Yes. So sometimes when you take a smear in the luteal phase, what you get are simply the cells are lysing out. The cytoplasm is breaking down and you can see lot of bare nuclei, and you have just the granular background of the cytoplasm that is remaining there, and abundant lactobacilli. So such a smear is called a lytic smear. In that case, what is the significance of this? You should not mistake the bare nuclei for the nuclei of neoplastic cells. So you should know that this phenomena occurs physiologically. Now, why are you seeing candida? Does candida have any preference of a particular vaginal pH? Okay, we'll come to that a little later. Now, this is just to show you very nice superficial squamous cells, pink, eosinophilic, pycnotic nucleus, and as compared to that, these intermediate squamous cells. When do you have a predominance of superficial cells?
Ma'am, these are in the reproductive age group.
But which part of the cycle, menstrual cycle?
In the ovulation, ma'am.
Pardon?
Around the ovulation, ma'am.
Yes, at the time of ovulation. So the estrogen causes maturation of the cells. Progesterone prevents the maturation of the cells. So in the first half of the cycle, you're going to get a lot of mature cells. Now, previously, as you know, that cytology was used for calculating the maturation index, knowing the time of ovulation in infertility cases. But now we have a lot of hormonal evaluation with a lot of and hormonal assays. So this method is outdated. But still, we need to know these basic features, because sometimes you do come across conditions like if it is a estrogen secreting tumor in the ovary, you in a woman who's more than 60 plus, and you are going to see a lot of superficial squamous cells, then you know that something abnormal, more estrogen hormones are being secreted in her body, and then likewise you can investigate her. Now, what are these cells?
Ma'am, these are
the
the
conventional smear.
Yes, ma'am. One conventional smear showing the endocervical cells in a honeycomb pattern.
Yes, and
Well, this is the lipid-based cytology, again showing endocervical cells in columnar pattern, and this is the cartwheel appearance. So
Perfect, perfect. Now, what are the different other patterns that you see? What is this pattern called?
this is strip.
Yes. Other word for this?
Fence.
Picket fence,
Picket
ma'am.
fence, yes, picket fence.
Here you are having a combination of both picket
Yes.
fence at the periphery and an end-on appearance of in the
Honeycomb.
center where you are getting honeycomb. What are these cells? Do you get any metaplasias in these cells? You have tubal metaplasia
Yes,
Yes.
where you get ciliated cells. Here you can see a lot of cilia.
yes, yes.
What is this phenomena known as? There is a tuft of cilia without a columnar cell. Have you read about it? What is ciliocytophthory?
Yes, ma'am. Ma'am,
What is it?
cilias get detached from the cytoplasm and they get stacked with each other.
So what is the significance of that? Previously, there was a lot of emphasis on this. They start resembling parasites and some ova and many other artifacts. People start suspecting things, but recently there's no significance attached to this. But you do get this phenomenon many a times. Now, what are these cells? They are laden with. They are full of secretions.
Secretions.
Yes. So these are the goblet cell type of change. This is another type of metaplasia which you can see. And this happens in which phase of the cycle? The cells are very
Ma'am, secretory. In the
yes,
second
in the
half.
secretory phase. So the cells are very plump and juicy, and the cytoplasm is stretched with the glycogen that is filled in that mucopolysaccharides that have been filled in it. Now, what is this? What are these cells? They are very tiny. They are neither parabasal cells, superficial cells you can see very nicely over here. What are they? Now, this is a, pardon?
They're looking like inflammatory cells, ma'am.
Yeah,
Neutrophils
because
like
we
cells.
have not magnified them. So they are not inflammatory cells, they are reserve cells. This is a very unusual phenomena, and you get this generally in epithelium that are very thin and they are present beneath the glandular endocervical glandular epithelium. They are very small, even smaller than the basal cells, or they resemble the basal cells. They have a very high NC ratio, and sometimes they look triangular, and they are generally present in such concentrated patterns. Now what is the significance of this? You have a host of differential diagnosis of this. They can resemble histiocytes, they can resemble basal cells, and you can confuse them with small cell high grade lesion. And so you should know that how the reserve cells look, and they do come in this pattern in a smear. Now, before we see how we are going to report this slide, these features in a slide, we'll see our first slide. So this is our slide number 1. Now, what are these cells?
And these are endometrial cells.
Why you want to call them endometrial?
Ma'am, because of their 3D appearance, and they came as a ball like.
They are a ball of cells. But do you think in this woman with the DUB type of history, this is justified? We can get this? And what will you call it?
It will be called as exodus, ma'am.
Exodus.
Hyperchromatic crowded group.
It can also, these are the differential diagnosis like an exodus, hyperchromatic crowded group of cells, a three-dimensional cell group. It could be anything, right from endocervical glandular cells to endometrial cells to a HCG of abnormal cells. So here you're getting a cluster of cell wall. by and large in this field, what are all these cells?
Ma'am, these are navicular cells.
This one particularly is a navicular
Yes,
cell. Yeah. Rest of them are they intermediate or they are superficial, parabasal? What are they?
Intermediate.
In
Predominantly, they are intermediate squamous
intermediate.
cells. Yes. So as we said that the patient is undergoing a crowded type of phase of menopause where you have plenty. Now see the difference that you see in a conventional smear and in a LBC smear. Each cell is separated out, so that effect that you classically get in a conventional smear of a crowded smear pattern, that is not being seen here. They are pretty much separated from each other and separated by so many spaces over here. Now, what are these again? Very small.
And these are basal cells.
No, basal cells.
These are looking columnar cells, ma'am.
Yeah, I think their cytoplasmic head has been broken and they are almost becoming end on. So they are basically glandular cells, but they are so tiny that they could be endometrial cells. Okay, now we go to another cell group. What are these?
Columnar cells.
Yeah, they have, here you can see more amount of cytoplasm. And what are these? In this circle, you have these end-on appearance of the same cells, and here you have this columnar
appearance endocervical cells.
So, what are these cells then?
And these are columnar endocervical cells.
Now, you have seen so many groups of glandular cells. How would you try to report this? See, this is all folded cytoplasm. Now, if it comes to we'll come back to this slide. How are you going to report this? What was the specimen type?
Ma'am,
Say suppose, because I'm showing you, if we talk on the digitized slide, it's a LBC
liquid
preparation.
base
Preparation. That's what you have to. Is the specimen adequate?
Yes, ma'am. Adequate for evaluation.
Now, what is the definition of adequacy?
Ma'am, first of all, we look for the cellularity. In case of LCB, 5,000 squamous cells are there, and for the conventional smear, there are 8,000 to 12,000 cells. And in case of atrophic smears, there are at least 2,000 cells must be there. And if there are few abnormal cells present in the pap smear, that is considered as adequate smear. Then, ma'am, look for the endocervical and endometrial cells or
yes.
And
so you have correctly said all the criteria. Chinmay, so what will we write in over here? Before that, is it essential to have glandular cells to call it adequate smear?
No.
No, ma'am. For considering adequacy, the presence or absence of glandular cells is not taken into consideration.
This is a very big paradigm change after LBC has come and the Bethesda system has come, that it is not essential. But if they are present, you must mention them in this category. So what will you write over here? Specimen adequacy?
Satisfactory
Adequate for evaluation, transformation zone component present.
Yes, correct. If it is not present, do you mention even that?
Yes.
Yes, you will mention even that. Now, in the general categorization, this category, what are you going to write? What is
negative
this?
for intraepithelial lesion or malignancy, NILM.
See, whatever you write from top to bottom in any of these categories, it is mandatory to mention whether an intraepithelial lesion is present or not. Why?
The basic aim of doing the pap smear is to exclude any epithelial abnormality, and that too specifically presence or absence of HSIL. So,
Yes. So the very purpose of pap smear is it's a screening test for precancerous lesions. So If no lesion is there, you must mention that. What comes under other category?
Ma'am, the presence of endometrial cells in age group more than 45 years, ma'am.
So now the smear that we have seen, patient was 53 years old. What will you write over here?
Endometrial cells present in more than 45 years of age. We have to
Now,
mention
do
that
you
in
think it is out of phase bleeding?
out of phase is, ma'am, when endometrial cells are present after 12 days of LMP, ma'am.
Yes.
So,
But with the history of DUB, when she doesn't know when she started bleeding, how long the bleeding lasted, and sometimes 12 days, sometimes 15 days, then what do you write? You simply mention that with because of her signs and symptoms of long-term bleeding and the presence of endometrial cells uh, in this category, you will write endometrial granular cells are present consistent with her signs and symptoms of dysfunctional uterine bleeding. That is what you mentioned. We know that she is more than 45 years of age. Epithelial abnormality, if it is there, you will mention. We have told that that is as an ILM smear. And now what is this category for then? We have already written everything over here. Now what to do?
to describe the findings, ma'am.
If you want to go towards describing in details, if there is a lesion, you can describe. Otherwise, sometimes people prefer this is optional as it is written in bracket. So in the interpretation and result also you can mention NILM and everything. And here it's important to mention in the general categorization the other. What is this section for? Additional notes or comment? Do
Yes,
you
ma'am.
want to put any comments in
Yes,
for this
for
particular
advice.
patient?
Ma'am, tubal metaplasia. We have seen the slide of tubal metaplasia here. We
Yes.
can
So if you
mention
see
that.
that you saw some cells, you write in details.
Yes,
Then
ma'am.
did you see some candida also?
Yes,
Yes,
ma'am.
yes, ma'am.
Yes,
So
ma'am.
you have to. So how do you report candida? What is the term exactly used?
Fungal organism
Fungal
morphologically
organisms
consistent with
morphologically
candida
consistent with
species.
Candida.
Group of
Species.
organisms. Perfectly right. You are very well read. Okay. Now, when we were talking about hormonal effects on the cells, we need to count at least 300 cells. There should be only two types of cells. If a third, like you should have superficial, intermediate or parabasal. But once, if you get a third type of cell, then that probably there is a lot of inflammation which is causing inadvertent maturation of the cells, and you will get three cell types. And you must have pertinent clinical history when you are reporting when you want to report on the hormonal effects. Now, as we have already talked about this, now coming to case number 2, who can take it up? Shilpa. Shilpa, can I see you?
Yes, ma'am.
Just raise your hand, please. Okay, okay. Read the history. Can you hear me?
Yes, ma'am. But slide is not visible.
Why? It is.
She is 58 years old woman complaining of itching.
Okay. Now, what is this smear? In stark comparison with the previous smear. What are these cells?
Basal
Predominantly,
cells are predominantly seen.
Parabasal cells.
yes, you are seeing parabasal cells predominantly. Why you want to call them parabasal? Depending on the size
Size.
of the cell. So go on telling me, what is the size of the cell?
15 to 30 micron, ma'am.
Okay, how's the cytoplasm?
Cytoplasm is dense, ma'am.
Cytoplasm is
Dense.
dense blue-green, ma'am.
Margins, how are they? Sharp. Most of them are having
Most
very
of sharp margins, yes.
sharp. How is the NC ratio? In a parabasal cell, what's the NC ratio like?
Little bit
NC ratio is
higher.
more compared to intermediate cells.
But how
And
much more?
the size of the nucleus is larger than that of the RBC.
Yes, but how many times the size? The RBC 7 to 8 micron millimeter. This, how much do you call it? It's 8 to 9 micron millimeter in size. Okay, now is there any variability in size of the cells? Yes, there are a
Yes, ma'am.
variety of sizes of these cells. So depending on the maturation, you'll have a little variation in the size. They are not very monotonous, and that we are going to see in the digitized slides also. Now here what has happened to these cells? Have they become little angulated? And they
Yes,
are
ma'am.
trying to snugly fit into each other.
Yes, yes, ma'am.
Yes, ma'am.
So what you want to call them?
Metaplastic cells, ma'am.
Plastic cells.
Plastic cells.
Yes, so they are metaplastic cells. Now again, this is the low power of the same. What is this sheet? This is a conventional smear. Now
Sheets
this
of
is
parabasal
LBC
cells,
smear.
ma'am.
These are all parabasal cells. So the parabasal cells, they have a tendency to keep fuse with each other. They are present in stacks. They do not separate out so easily with each other. They are very compact. But in LBC, when there is a lot of shearing force, the vortexing of the vial, each cell separates out, and majority of the cells are separated, and you will see very few cell clusters as against a conventional smear. Now here you are seeing in this LBC smear, you are seeing a stack of cells, and these are the single parabasal cells. Now, what are the features of, what do you think you want to call this condition as?
Atrophic smear.
Atrophic smear, ma'am.
Atrophic smear. Okay, now this is a conventional smear. What are these cells? This whole
Sheets of
sheet.
parabasal cells.
Yes, again, this is a whole sheet of parabasal cells. These have slightly high NC ratio, dense cytoplasm. Here they are pulled, that's why they are looking, the nuclei are looking oval, but here the nuclei are generally very round, and it's located in the center of the cells. Now, again, this picture has come. Some you are seeing these new structures over here. In the center, you see this. What are these?
Stripped nuclei, ma'am, these are.
Yes, perfectly correct. They are bare nuclei of the parabasal cells. They have that the cytoplasm, though it is so dense, it is not very sturdy as compared to the cytoplasm of superficial and intermediate cells. It's very fragile. So when you're spreading the smear or agitating the vial, the cytoplasm is lost. What is the significance of this when you start seeing such clusters of bare nuclei?
In atrophic smear, ma'am, there will be bare nuclei.
But what is the risk? I can
With
interpret it as something else. What are the differential diagnoses of such bare nuclei clusters?
material cells.
HSV cytopathic effect, ma'am.
No. See, they are very
Endometrial.
small, resembling endometrial cells. Here again, you are
Cells.
seeing a cluster forming an acinar pattern, but they are all bare nuclei. You start misinterpreting them as atypical glandular cells or adenocarcinoma cells or a small cell. See this cluster here, there is overlapping. These are all bare nuclei. You start interpreting them as a small cell type of HSIL as we talked before. So you should be aware that bare nuclei of parabasal cells are very common in an atrophic smear. Likewise, you get this background. What is this background called? This is the background because of the disintegrating cytoplasm of the parabasal cells. And see the nuclei. What is this effect called as? This is an atrophic smear. The nuclei are very
Large.
Drying artifact.
Yes, this is because of the drying artifact. What a drying artifact does, the nuclear staining becomes very dark because there is improper fixation. And this muck that you are seeing, the proteinous material that you are seeing, or sometimes they call it coagulative material of the cytoplasm, it is this granular material, and it is not necrosis. So an atrophic smear will sometimes have a very dirty background, granular background, because of the coagulative degeneration of the parabasal cells. and the fragile cytoplasm, and combined with these dark nuclei because of lack of fixation, you can misinterpret as a high grade lesion in some of the cases. Now, what are
The
these
cell
cells?
which is seen on the left side, ma'am, is it a atypical paratotic cell, ma'am? Parakeratotic cell, ma'am?
This one, it's looking like that. We will see how but see, it's degenerated. You are not able to see the nucleus very clearly. Now this one, what are these?
The lower one, ma'am.
All of these, what are these?
Multinucleated cells.
Multinucleated giant cells.
We're seeing many multinucleated giant cells. Again, this is from a case of atrophy. What are these? Again, this on this right side, I'm showing you.
Metaplastic cells.
No. This again, this is a giant cell
Yeah, yes.
with a lot of engulfed polymorphs inside it. Can see?
Yes.
So this is this a histiocytic giant cell, and what are these giant cells then? This
By
looks,
intermediate cells, ma'am.
yes, this is an agglomerate of intermediate cells forming giant cells.
Yes.
So this is one of the features of atrophy. You can sometimes get plenty of giant cells, and they are simply agglomerated intermediate squamous cells that you get in atrophy, both intermediate, sometimes intermediate type of atrophy and sometimes parabasal type of atrophy. And these cells, this is a classical histiocytic giant cells. You can get even these cells in atrophy, and as you can see, there is a lot of inflammation in the background, so it is a inflammatory smear. Now I'm just showing you a few clinical pictures. The epithelium of the atrophic cervix is very fragile. See, when you start taking a smear, it easily bleeds and you get so much of subepithelial hemorrhage. And there is excoriation of the epithelium. The cells, as I told you, they are very fragile. The cytoplasm disintegrates very easily, and it is very thin and parchment like, and you get such bleeding spots after you take a smear. Epithelium itself is very thin. Now, before we go to this, we will see so at the pointer you have a
Multinucleated
Giant
giant
cell,
cell.
Multinucleated giant cell.
Shilpa is taking the responsibility, no, of this case. Shilpa, we were talking to Shilpa, no? Okay, what are the cells in the background? Predominantly, how are the cells looking? Now, what are the size and shape of the cells?
Ma'am, predominantly there are parabasal cells in the background,
Yes.
along
Mhm.
with along with intermediate cells also.
Yes, some superficial and
Yes.
some intermediate cells. And there is a nice variation in size of the parabasal
Yes.
cells. You have the deeper ones which are much smaller. You have the higher ones which are towards the intermediate type of cells. They are slightly more mature, so they have less dense cytoplasm. Now, overall, the cytoplasm of the parabasal cell will be very dense, and sometimes it is two-tone. At the periphery, you have denser cytoplasm, and at the center, you have pale staining of the cytoplasm. So, as we had seen in that, you have a giant cell over here, and you have predominantly parabasal cell in the background. As we were talking about the crowded sheets of cells, see, even if this is a liquid-based preparation, you have a dense sheet of cells, crowded, fused cells. Another sheet of fused parabasal cells. Now here you can see the desmosomal junctions. If you in a conventional smear, if you try to spread it vigorously on the slide, the desmosomal junctions, they separate out, and then you can see like a frayed margins of those parabasal cells. What are these?
These are endocervical cells.
They are glandular endocervical cells. These again, are they squamous or are they glandular? So such dilemmas do come. They are very crowded. How is the cytoplasm? How will you differentiate? See here, whenever the cell group is very crowded, you have to observe the features at the periphery. So here in the periphery, you can see some tails of cytoplasm. Cytoplasm is more dense. You are not sure whether this is an endon sheet. We saw such beautiful honeycomb sheets. But is this a honeycomb sheet?
No, ma'am.
No. These are squamous cells. Okay? And again, they are those compact groups of squamous cells. If you have any questions, keep asking because we have to move. Now, we were talking about the granular material that sometimes you can see in the background. You can see all this material?
Yes, ma'am.
And do you find any difference? And you can see some bare nuclei also in these areas. See these nuclei? They are very small, dark, and then you start suspecting whether you are dealing with any atypical lesion. So this was the low magnification. Now, is such a, I mean, the appearance of the whole slide is a very typical smear that you see in atrophy, late atrophy.
Dr. Kamal, can you make it a laser pointer, please?
Okay, it will come there on that side. I will do it. Here, I don't think it comes as a laser, Sumit.
It's okay. It's okay then. It's okay.
Yeah. So the overall appearance of the smear is that of atrophy. Now we will go back. Yes, we were talking about bare nuclei. One more annotation. See, these very tiny cells are there. They could be reserve cells. They could be deep basal cells. You can mistake them for endometrial cells. So you have to be very aware what all structures can come in this form. They could be simply bare nuclei of the parabasal cells. But all in all, this looks like a very normal smear. Now, how do we report this?
Specimen type is liquid-based pap smear. Specimen adequacy is adequate for evaluation.
Yes.
In general categorization, there is NILM.
No, in adequacy, did you see any glandular cells? We did see some.
Yes, ma'am.
So what will you mention in addition? Transformation zone component is seen that you have to add. Okay, any doubt, Shilpa? Now in the general categorization, Shilpa, are you there? Shahnaz, can you say?
NILM.
Yes.
In general categorization.
Mm.
In other, we did not see endometrial cells.
Okay.
So will not write that. Epithelial abnormalities also will not comment, ma'am. Then we will go to interpretation or result.
So it will be either of the two. Either you can describe under this or in this category. Now we haven't seen any endometrial cells. One thing I told you in the beginning that she's a postmenopausal woman. The age was reflecting and she had itching. What is the relation of itching to such a type of smear?
Ma'am, atrophic vaginitis is a common association in atrophic smears, ma'am.
Yes, very correct. There is a lot of dryness and that causes itching. And another thing, if you can, we haven't seen anything over here, but if you see some bodies, candida,
Yes,
so you can have. And sometimes because of this type of itching, for the first time the patient undergoes investigations and she is detected for diabetes. That's one of the causes in such patients, and this is how they are sometimes discovered. So different infections or systemic disorders and simply physiological. These could be the different reasons. Now, what have we learned over here? In an atrophic smear, you will have a parabasal predominant maturation index. And how do you express it? There is a shift to left. So you were seeing mostly parabasal cells and then intermediate cells,
80-20.
and we did not see any or very
Superficial cells.
good. So this was a very late menopause. And when all you see this type of pattern, come on, read it. Late menopause, late post-menopause, postpartum,
And lactation.
lactation, and childhood after 1 month. Okay, in a child also the predominant pattern will be of the parabasal type. What happens before 1 month? What pattern will you see? Predominant pattern will be of which type of cells in a neonate?
Intermediate cells.
Intermediate.
Yes. Why? Why?
Estrogenic, maternal estrogenic.
Not estrogenic, progesteronic, maternal progesteronic
Progesterone effect.
effect. And long-term progestin contraception can also cause a parabasal predominant pattern. Although we say progesterone causes a predominant intermediate cell type of pattern, but long-term progesterone leads to a parabasal type of pattern. Now coming to case 3, any questions on the case 2? Sumit, do we have any questions from in the chat box?
No, ma'am.
Okay. Now case 3.
No, ma'am.
Okay, thank you. Deepmala can take, or Deepmala is not connected well. Nupur, can you take?
Shilpa is here. I think Dr. Kamal Shilpa is now available.
Okay. Shilpa, we go to case number 3. This will be very short, but good features.
Ma'am, I'm not able to see any slide.
Okay.
Maybe her connectivity is poor, Shilpa. So I think
Chinmay?
we'll have these three only. These three students' connectivity is good. Aparna, Shanaz, and Chinmay.
So Aparna can do it.
40-year-old lady, LMP 9 days back.
But her voice is breaking, huh, Sumit? I can't hear it properly.
Yeah,
But
little bit.
Aparna, can you see the screen and everything nicely? Let's
Yes,
try.
ma'am. I can see the screen.
Okay, so 40-year-old lady, LMP 9 days.
LMP 9 days back.
What are you seeing in this slide? In this picture?
We are seeing predominantly the endometrial cell clusters predominantly.
You are very sure they are endometrial cells? Why? Why they are endometrial cell clusters? They are some glandular cells, isn't it?
Okay, ma'am. Okay,
So
ma'am.
why they are not endocervical cells? And why they are endometrial cells?
Ball-like clusters, tight ball-like clusters,
Three-dimensional cell balls.
three-dimensional cell balls type clusters.
Another feature, second feature, they are very small as compared to the endocervical cells. We have seen endocervical cells are more often columnar, more abundant cytoplasm. Here you cannot see the cytoplasm. In this picture, this is the LBC preparation. See how tiny and small these cells are, and you just see the knobby ends at the periphery. Now, what is this pattern known as? Drop hat pattern.
Wreath-like arrangement, ma'am.
Wreath-like arrangement, drop hat pattern. It looks like a hat. What is at the periphery? So this is a string of exodus, clusters of endometrial and stromal cells.
Okay, ma'am.
What is at the periphery? They are the endometrial cells, small
There are
round
small the clusters around the periphery are loosely they are loose when they compare to the center clusters which are tightly which
So
are
what
found
are
in
the cells in the center? Which cells are those in the center? They are the stromal
Stromal
cells.
cells.
We all know that we can get a stroma when there is crumpling of the endometrial lining in the menstrual periods. You get both the stroma and the endometrial cells coming into the smears or into the cervix and the vagina. Again, another three-dimensional cell ball. What is the configuration of this? They are looking like
strip.
Tubular, the glands of endometrium, they are tubular. So you're getting such tubular three-dimensionals at branching.
Okay.
Yeah. And now what are you seeing here? Here again there is a dense cluster. Maybe it is calcified, a samoma body-like thing. This is also very dark, very suspicious looking. But these structures you do get when you're seeing endometrial material in a cervical smear. And what are these cells? They are having little more abundant cytoplasm. These are also endometrial cells, and they are typically named as sticky histiocyte type. And then they come from the stratum functionalis of the endometrium. You have the two layers, the stratum basale and the stratum functionalis. So the cells that you're getting from the stratum functionalis, they are sort of sticky histiocyte-like, fuzzy margins, and the cytoplasm is also not, it's abundant as against what we describe as very scanty cytoplasm. So these are all the features that you can see when you get endometrial material. Now, what was the LMP of the patient?
9 days.
9 days.
9 days back. So is it significant to report? Now, what else you will get in a smear apart from these endometrial cells? How will the background be?
Inflammatory.
Cells.
It can be inflammatory. It can be clean also many times. But what is more important, you will get a lot of histiocytes and you will have granular material also. And those histiocytes, they will be disintegrating. So what all components of menstruation that you are going to get will be reflected in the cervical smear. Here again, this is a liquid-based preparation. These are just three-dimensional cell balls. Now, sometimes you get these cells. What are these cells? Just describe one of these cells you are seeing in both the fields.
Vacuolated cytoplasm.
Vacuolated cytoplasm. They are single cells.
Vacuolated cytoplasm. Well-defined vacuolated cytoplasm.
Okay. And then you have an eccentric nucleus.
Eccentric nucleus.
If I tell you that this woman was wearing an intrauterine device.
Yes, ma'am, it is possible to get the vacuolations in the cytoplasm in case of intrauterine device.
So that is the importance of having history. One thing you should know the LMP of the patient, and second you should know whether she is using any intrauterine device, because you can mistake these cells for
Signet cells.
Signet ring cells.
signet ring cells of adenocarcinoma. Here also you are seeing the same feature. Then you have to focus more on the nuclear atypia. So once you know the history, so you are sure that it is because of the IUD that she is wearing. See, I was talking about histiocytes. These are multiple histiocytes along with acute inflammatory cells. You can see reniform nucleus in one of these. And then you have vacuolated cytoplasm in these cells. Again, now this is another patient with wearing an IUD. You can see these vacuolated cells. This looks like a what type of a cluster? Mimicking a, or differential diagnosis would be a adenocarcinoma type. When you call, you have a cell cluster with vacuolated cells, eccentric large nucleus, you start suspecting that whether or not cells from adenocarcinoma are being shed. So you need to ask for history of the patient. What is the status? Now, before going to this one, we will what is this?
Endometrial cells, ma'am.
Yes.
Endometrial
So
cell
very
clusters.
small. Yes. Scanty cytoplasm. We'll Try to see all the features that we talked on the fixed slides. Now, what are these?
These are columnar type cells, ma'am. Glandular cells,
Not
endocervical.
exactly columnar. I thought they were stromal cells. These are glandular cells, some stromal cells with spindle oval nuclei. What is this appearance? The drop hat appearance that we saw, but it is slightly distorted, not that fine that you saw in that conventional smear. Peripherally, you have these glandular cells, and in the center, you have the stromal cells, which cannot be seen separately unless they are lying separately in the smear. Now, you can see this granular muck, which is present, dirty, necrotic, crumbling material coming from the endometrium. Now, here again, what is this?
Columnar type.
Are these endocervical or endometrial? Although they are looking columnar.
Columnar type, they do look like columnar.
Yeah. So they are
Endometrial look
endometrial
like
cells.
cells like.
Yeah, they are low columnar cells, and these are the strips, and here you are having some crowding of those stromal cells. Again, you have this cluster, three-dimensional cluster. So unless you know the LMP of the patient, you can misinterpret this as hyperchromatic crowded groups of cells. Now see, these are again low columnar cells that are again coming from the endometrium. What are these? These are pretty clear. This is what picket fence appearance of
Endocervical.
endocervical cells. These are very small glandular cells. See how tiny they are, and less three-dimensional. And here you can see this, which is this cell? This is a normal columnar, endocervical columnar cell. So you have the difference here itself. Again a 3D wall. Again the appearance called as a wreath-like appearance or a drop hat appearance. You can see at the periphery the glandular cells, and in the center you're getting these stromal cells. So you have that visual picture of this exodus, how it is seen. So you have to keep in mind, and of course apply all the criteria that are required to differentiate and these cells from atypical glandular cells, atypical squamous cells, or any other lesion that we will see in the coming few slides. Just close one or two windows. How will you report this? Yes, Shilpa? How will you report this? Specimen type?
Type, liquid base smear, specimen adequacy, satisfactory evaluation, endocervical cells present, general
Then?
categorization, NILM.
Yes. Tell me the full form. Don't talk in short forms.
Negative for intraepithelial lesion or malignancy.
Yes. And in the other? You saw so many endometrial cells.
Yes, ma'am. Endometrial cells in in small 3D clusters and
Now,
small
do you
clusters.
want to suggest in the additional notes, do you want to suggest any investigations to the patient, or you feel that it's absolutely normal looking at her history and her LMP that was given to you? What was the LMP given?
9 days back, ma'am.
9 days back. So do you think she should undergo any investigation for knowing the status of the endometrium, or is it is physiological? Yes, Chinmay, Shehnaz, आप लोग बोलिए.
It is
Ma'am,
physiological, ma'am.
endometrial cells present correlate with the clinical history provided, ma'am, because between the day 6 to 10 of
Yes,
menstrual cycle, it is normal to find such kind of cells.
yes, and perfectly right. And plus,
Less
the
than
patient is not more than 45 years
yes,
of
ma'am.
age.
Less than 45 years age, even if it is out of phase endometrial cells, we need not report,
Mhm.
ma'am.
Yes, perfectly correct. Okay, so we'll just move ahead. Just to highlight, Aparna, can you read out the differences? These you must know because this is a very important diagnostic pitfall. All of us till this age, we fall prey to these cells, like we don't know whether they're endometrial, atypical, or they are endocervical. So we need to remind ourselves of these criteria again and again. So endocervical cells, they are, go on reading.
Endocervical cells are larger, endometrial cells are smaller.
And we saw this, I think you are convinced about it in
Yes,
the
ma'am.
slides. Then, hmm, they are more, Chinmay, you can talk if this sound, they are more variable in endocervical. Here, endometrial cells, they are
Endometrial
more,
cells are more uniform.
yes, next point, Chinmay.
Not visible, ma'am.
Ma'am, the endocervical cells present as flat 2D sheets, while the endometrial cells are presenting as crowded 3D balls.
So you were convinced about this point also?
Yes, ma'am.
Yes, ma'am.
Hmm. Here you can get honeycombs and palisades. Here also we can get honeycomb and palisades, but we did not see any honeycombs of endometrial. But we did see palisades of endometrial, the low columnar cells that we saw. Agree?
Yes, ma'am.
Yes, ma'am.
Yes, yes, ma'am.
Next point. Nuclei vary in size, not shape. Whereas with endometrial cells, nuclei will vary in shape but not in size. Their size remains very small, constant. Multinucleation is common with endocervical cells. We haven't seen that. Multinucleation is rare with endometrial cells. Cytoplasm, you agree with this? You saw abundant cytoplasm in endocervical
Yes, ma'am.
and in
Scant.
endometrial,
Mm.
it's very
Scant.
scant. And one important feature is that you have endocervical cells are more sturdy, they are better preserved, and by and large, most of the times there is a lot of degeneration in the endometrial cells that you get. That's why they are so difficult to interpret. Either their cytoplasm is disintegrating, they are becoming as bare nuclei, or their nuclei themselves are degenerated, so you cannot identify them properly. So these are the problems with the endometrial cells. This you have already told me. What are the other causes? Please read out. Hormone replacement therapy, Chinmay. Oral pills.
Oral pills, ma'am.
Hmm.
PP, IUD, ma'am. Dysfunctional uterine bleeding, endometrial hyperplasia or carcinoma.
Yes, these are the common
Postpartum
cause of
period.
getting abnormal shedding of the endometrium. So when you are in doubt, you need to extract this history from your gynecologist. And previously we used to use the posterior vaginal pool sample to identify any endometrial shedding and if there is any for abnormal hyperplasias that were seen radiologically. And we know now very clearly exodus are the days 6 to 10.
6 to 10.
Yes.
Okay, now case number 4. Who can take it up? Deepmala, can we hear you? Tupur?
Yes, ma'am. Yes, ma'am.
Deepmala can take it up? Okay, fine. Your connectivity has come. Read the history.
27-year-old woman complaining of foul-smelling vaginal discharge.
Okay. What are you seeing?
Lights are not moving.
Hmm? What are these?
Some smears show plenty of inflammatory infiltrate
Yes. But what is this pattern?
covering the squamous cells.
No,
Pus
I
balls,
can't
ma'am.
see any squamous cells over here.
Pus balls, ma'am.
Yes. So they are aggregates of polymorphs, also known as the pus balls. What are the other names, Chinmay?
BB
Volleyball
shot.
appearance, ma'am.
Polyballs, BB shots,
Cannonball appearance.
cannonballing. And what is there in the insect?
superficial squamous cell
Single one.
and trichomonas vaginalis attached to it.
So you have identified it very nicely. Now describe this organism. Here again you are seeing these bodies. Describe, Kamal.
Ma'am, pear-shaped organism.
Oval, pear shape, kite shaped. These are the terms that are used. Here you can see one, here you can see. These are all small bodies that you can see in the background. What else? What is it containing? What is more important? The shape is not important for its diagnosis.
Eccentric nucleus and red granules in the cytoplasm.
Yes. So we are seeing a rectangular eccentric nucleus and some redness is seen over here, but that is very difficult to see many a times. And another feature which may or may not be seen is no in the structure of the trichomonas.
Flagella.
Flagella. So, are you seeing it?
No.
Do you see it so regularly?
No.
No, it's gone because of the preparation of the smear. Now here in this field, what has happened to this squamous cell? You can see these bodies over here. TB bodies are seen, plenty of them. How's the background over here? Plenty of TB bodies, and how's the background? Can you identify any squamous cell over here? Most of them are disintegrating. So there is lysis of the squamous cells. And because of that, there is a dirty background. Here you can see this granular necrotic material or the lytic material coming from the cytoplasm of the squamous cells. So you have seen three features till now. One you saw was the first one was the polyballs. The second is the dirty background. And what is this? This is polychromasia, two-tone staining of the cytoplasm, that also we will see. Now here what are you seeing? This is the liquid-based preparation.
Squamous cell, ma'am, with perinuclear halo.
So what do you call, why is it there?
The infection change.
Agreed, but what does the infection do to the cytoplasm? And what is this? These cells are almost, the nucleus has become very pale. So they are degenerating. And the degeneration starts closer to the nucleus, and that's why it creates a moth-eaten appearance of the cytoplasm. So irregularly eaten up cytoplasm around the nucleus, that's where it starts. And then you have a classical term uses the moth-eaten appearance of the cytoplasm. Now, some people can mistake this for a perinuclear halo.
Yes.
When do we get that halo?
Poilocytes.
In poilocytes. So we need to know what are the criteria and what are the specifications that are used to distinguish poilocytes from perinuclear halos because of other causes. Now, one thing which helps you in telling you that these are not the halos, of course, there are many points in this, but one thing is that they are uniformly present in all the cells. Most of these squamous cells are showing this type of disintegrating cytoplasm or perinuclear halos. Now, what are these? In inset, you are seeing something. Here, you are seeing something very long, filamentous.
Leptothrix.
Leptothrix. What is the association of leptothrix with?
Vaginalis.
Trichomonas vaginalis.
Yes, what is the association? When you see leptothrix,
Trichomonas
there are high
vaginalis.
chances, 40% chances that you're going to see a trichomonas vaginalis. But the reverse is not true. Now, what do you call this thing, structure?
Spaghetti
Ball of hair. They are very thin, as if you have combed your hair and made a small round ball and thrown it away. So they're very delicate, filamentous, long, and they form balls. So some people want to call them like spaghetti. And then these bodies that are seen, spaghettis and meatballs, that is the term that MacD may uses for these leptothrix and TB combination. Now we'll just try to see. So I've put an arrow. What are these bodies? Can you identify them? Can you appreciate that they are TB bodies?
Yes, ma'am.
Antibodies, yes.
See, you can see the small rectangular nucleus, very fuzzy margins, and they are clinging to the margins of the squamous cells. See, there are plenty of them present. Now, what is the pathogenesis of formation of pus balls? Now, what is this other feature over here? What are these cells? Can you identify these cells?
Superficial cells, ma'am.
Two cells, ma'am.
They
Two
are,
cells, ma'am.
they are superficial cells, but they are covered with coccobacillary flora. So in this, there is infection because of two organisms. One is the TB infestation, and the second is the shift towards coccobacillary flora, that is known as Gardnerella
Vaginals.
Gardnerella vaginalis.
Now, when you have infection, they are generally polymicrobial. You can have even bacteria, gonococci, and multiple infections, candida together. You can have two or more infections together. Now, what is this? This is a superficial squamous cell. What is
Binucleate.
binucleated, and some amount of halo is present around it. See this kite-shaped TB? Here we are trying to highlight the dirty background, which I showed you in conventional smear. And here is the formation of the pus ball. Now, can you, Chinmay, highlight how these pus balls are formed? They are very typical. That really helps you to identify the TB in the smear. Right in the beginning, I showed you that the TB, they cling to the cytoplasm of the squamous cells. Once they cling, the polymorphs start engulfing them, or they come very close to these clinging TBs, and that is how the whole cell is covered with the TB. The whole cell is covered with polymorphs, and everything is disintegrating, and what is left behind is a polyball or a pus ball. So here you are getting a pus ball, but there must definitely have been a squamous cell and the clinging TBs to this. See the dirty background, the cytolytic background, and plenty TB bodies all over the slide. And now here there is a nice agglomerate of the Trichomonas vaginalis bodies. All of these are TB bodies. They are giant ones. And this is again the formation of the pus ball. This is what I wanted to just highlight in this slide. So how are you going to report it? How will you report this? Deepmala? Specimen type? We can't hear. You are there, Deepmala? You are there?
Specimen type would be LBC, ma'am.
Yes.
Specimen
Satisfactory.
adequacy, ma'am, adequate for evaluation, ma'am. But we have to write that 50 to 75% obscuring component of inflammation is there.
Yes, but was that a limiting factor in interpretation?
No.
You could not
No,
interpret these as it was not. You still could interpret, but when the smear is I mean it is adequate, but still you cannot see all the features. In that case, you can completely obscuring inflammation is seen. That's what you will mention. And if you want to mention, of course, you can describe partially obscuring inflammation is seen, but there is no compromise in interpretation because you can report this category. Could you feel that you could comfortably report NILM?
Yes, ma'am.
You could see all the nuclear features. There was no confusion between some coilocytes or anything else. Did you see such any endometrial cells over here? No, we did not see any of these cells.
No, ma'am.
Okay. Any additional notes or comments? This you still have to write something over here. What you saw? All the infecting antigens.
Trichomonas vaginalis identified, ma'am, and shift in flora suggestive of bacterial vaginosis because we also seen the clue cells, ma'am.
Yes. Now, generally, there is a trend that we write over here: treat
Wet
and
mouth.
repeat the smear. Okay. Now, did you see any reactive cellular changes associated with inflammation in this, which created some doubt whether there is some atypia or not? You
Yes,
did
ma'am.
see some?
Yes, ma'am.
Binucleation and perinuclear halo
Perinuclear
was
halo
there.
was there.
Yeah.
Yes,
But
ma'am.
that
So we can
perinuclear
write, ma'am, reactive cellular changes associated with inflammation.
with inflammation are seen. That will come in your interpretation and result. And here you can even write all the features that you saw: coccobacillary flora, and the perinuclear halo that you saw was not consistent with or did not create any doubt about HPV infection. And you can write as many notes as possible. But what has to be very clearly mentioned is this portion. NILM has to be very clear, because even if you suppose you do not write that you saw TB or you saw coccobacilli or shift in flora, the clinician has the whole patient in front of her. She is having all her signs and symptoms, and after taking a smear, she must have already given her the broad spectrum antibiotic and intravaginal pessaries, etc. So it sometimes really doesn't matter if we report to them these findings or not. But once we are seeing, as pathologists, we are seeing some interesting findings, we must mention and we cannot ignore it. And of course, secondary, all these infections can create confusion with intraepithelial lesions, and that is why we have to make a habit of reporting whatever features we are seeing, atypia or any infectious organism, this, that. Because sometimes the clinicians, if Dr. Maheshwari is here, she will tell us that, oh, it doesn't, we don't need all that. We have already given her cocktail of antibiotics and everything, and she's being treated. So what is important is to mention that there is an NILM. Sumit, are you there? It's already 8:30.
Yeah,
What do
means
you want?
it's perfectly fine. You can carry on. I think there are still 200 almost audience attendees apart from students.
And my team, are you tired?
No, ma'am.
No, no.
No, ma'am.
No, ma'am.
Finding interesting or not?
Yes,
Yes.
ma'am.
Yes, ma'am.
Going very well, Dr. Kamal. Thank you.
Thank you. Now, one point you have to remember clinically how the cervix looks. See, it looks like a strawberry appearance. And because of trichomonas vaginalis, there is acute dilatation of fine capillaries beneath the squamous epithelium. And they are dilated like this in a patchy manner, and then it creates clinically a strawberry appearance. This we have seen a number of times in our patients, and this is what the clinician sees on clinical examination. So just repeat once these features. Pus balls we saw.
Yes, ma'am. Dirty
Dirty
periodic
Cytologic
background.
background, ma'am.
Yes,
Moth
we saw
eaten.
moth-eaten
Moth-eaten appearance of the cytoplasm.
It's also
Rich
known as
halos.
strict
Rich
halos.
halos.
Yes, we saw bare epithelial nuclei, and because of the cytolysis, and we saw the association with leptothrix.
Leptothrix.
And some people add polychromasia of the cytoplasm, two-tone coloration of the cytoplasm. Even the superficial cells, they start having a green or cyanophilic and mixed with eosinophilic cytoplasm. Now coming to case 5, Chinmay, you can take it up.
Yes, ma'am.
This is, we'll go fast with this, very clear
Case
cut
number
case.
5, ma'am. 35-year-old executive screening.
Yes. What are these? What is the cell type?
These are the intermediate cells, ma'am.
Why? Why not superficial? Okay, what are these cells? Okay, okay, superficial, intermediate squamous cells. Superficial cells, they do have very transparent cytoplasm. So I feel that this here the transparency of the cytoplasm is more as compared to, see this cell, it has a denser cytoplasm. Here you have more dense cytoplasm. Okay. So these are more mature squamous cells. Okay. Now, anything has happened to the size of the cell?
The size of the cell is reduced, ma'am, and there is nuclear membrane irregularities which are seen here,
No,
ma'am.
no, no, we won't jump to that immediately. There is definite cytomegaly. These are larger than the normal superficial squamous cells. Okay, so there is cytomegaly, there is nucleomegaly, but how is the NC ratio still? Is it high
It is
or
within
low?
normal, low
It
only,
is
ma'am.
still low. Okay. Now, what is the size of the nucleus? If you try to mentally fit RBCs, how many RBCs will fit inside each of the in this nucleus?
Around 3 it will.
Two,
Up to 3 you feel.
ma'am.
Okay, in this one, is it slightly more? The cytoplasm is folded, so you are not sure whether it is binucleation or not. Here, there is definitely some binucleation. Now, what has happened over here? Again, there is cytomegaly. You have seen so many cells
Yes,
till
ma'am.
now. There is
Yes, ma'am.
cytomegaly. Giant cytomegaly, you call it. There is nucleomegaly. Is the nucleus very
Yes, ma'am.
smooth, round?
No, ma'am.
What
The
is the
nuclear
shape of the
membrane
nucleus?
irregularities are present.
Yes, and it's become like somewhat rectangular, irregular margins are there. Okay, here you can see
Yes,
some
ma'am.
amount of hallowing. Here also you can see a dark nucleus. We would like to call this, any word for this? Would we like to call it resinoid? It's
Yes,
shrinking.
ma'am.
Yes, ma'am.
It's slightly shrinking. We'll see better resinoid nuclei. Here you are seeing more enlargement of the nucleus than shrinkage. What are you seeing here? Very obvious. Multinucleation. Here there is
Yes, ma'am.
nucleomegaly, and all of these are mature squamous cells, and you are seeing this multinucleation, binucleation. You will see most of them, many of these abnormalities. Now, what are these? Just name it and tell me what are the criteria.
These are coilocytes, ma'am,
Okay, so what
also
is a
known as
coilocyte?
perinuclear cavitation. The cytoplasm is condensed
How big
towards the.
should the cavity be? Each feature has a criteria. How big should the cavity be? It should occupy more than 2/3 of the area of the cytoplasm. Okay, then first
There is
come to the
peripheral
cytoplasm.
condensation of the cytoplasm.
What is that called? Wire looping.
Air looping. Yes.
Yes.
Ma'am.
Why does that happen? Why does that happen? And why is the cavity created? We know now these are all HPV cytopathic effects. So this is
Yes,
caused
ma'am.
by HPV. Coilocyte is a hallmark of HPV infection. We all
HPV.
know that. Yeah. So, but what is happening over here? Why this cavity has been created? There is disintegration and necrosis of the cytoplasm, and only the sturdier elements like the tonofilaments, they are resistant to this necrosis, so they are pushed to the periphery and they collect it over there and just hold up this cavity in the form of a dense margin or a very sharp thick margin. Okay, give different terms
Yes,
are
ma'am.
given to it. Now what is happened over here? There is, okay, the nuclear atypia and enlargement. Is it conforming to
Yes,
the
ma'am.
definition of
Yes, ma'am.
LSI nucleus?
LCL.
Yes.
Yes.
So what
Yes.
is the definition?
Ma'am, the size of the nucleus should be more than 3 times the size of the intermediate cell nucleus, which is considered as 35 micrometer square. So it would be more than 100 micrometer square, or it should be more than twice the size of the squamous metaplastic cell nucleus, which is of the size of 50 micrometer square. So the size of the L cell nucleus would be more than 100 micrometer square.
Perfectly. What has happened to the chromasia? Chromasia. What is chromasia?
Hyperchromic.
Course is regarding the chromatin.
Hyperchromatic.
These are hyperchromatic, ma'am, but sometimes normochromasia might also be seen in cases of LC.
Yes, you can see normochromasia, and particularly in which preparation? liquid-based
Liquid
preparation.
based.
Okay. So here it's very hyperchromatic. Now, what has happened to the coarseness of the chromatin? There are coarse particles all over.
Yes, ma'am.
But and what? How is the membrane of the nucleus? Both the nuclei. How is the membrane?
These are somewhat regular only, ma'am.
It's regular. It's not that irregular. So would you still
Yes, ma'am.
like to call it as a collocyte?
Yes, ma'am.
Yes. Yes. Because important is the size of the nucleus.
Cyto.
The nucleus should be 4 to 6 times the size or more than 3 times the size of an intermediate cell nucleus. Now all the findings are fitting here also: binucleation, multinucleation, and you have, I mean, this is degenerating. So the slight hypochromasia is there. Here you can see the hyperchromasia. This cell, this is a liquid based preparation. Now what has happened to this? How will you describe this nucleus?
There is nucleomegaly, ma'am, and a hyperchromatic nucleus is there with regular nuclear margins.
Is it this hyperchromasia and this hyperchromasia is the same? Here you can see the chromatin particles. I can at least see, I hope you can see it. But here what has
Yes,
happened?
ma'am.
No, there is a term used when you
Yes.
cannot see the texture of the, what do you call it? A smudged nucleus. So this is a
Ma'am.
dense smudged nucleus, a very large nucleus, and these are all the features of HPV infection when they involve the mature cells. Now again here you can see the nuclear membrane irregularity. Here the shape of the nucleus has changed. Here there is multinucleation or a flower type of nucleus. What has happened over here? There is no wire looping, but there is enough
Binucleation.
binucleation, and more than two-thirds of the area of the cytoplasm is occupied by the clear area, multinucleation, hyperchromasia. So you had all those. What were those? All of them?
Coilocytic change.
What a
LC.
second. What was the slide number that was written?
5.
14.
Case 5,
14.
ma'am.
No, case
14.
5, 14, and 11 we have to see.
Okay.
Now, in the live pictures, how do you see it on a live slide? Because generally, when we take pictures for a PowerPoint presentation, fixed pictures, we take very classical features. Only in a live specimen, you have so many variations that create doubt whether or not this is a coilocyte or not. So that we have to clear out all those doubts and keep on applying the definition and the features to label it as an LSIL. So what are you seeing here?
There is peripheral condensation of the cytoplasm, and clearing is also seen more than two-third area of the cytoplasm. And
Yes, but
there is
you
also
should start
nucleomegaly.
always, sorry to interrupt. You should always start with cytomegaly, whether or not there is cytomegaly. The first criteria is that the cells are very large, and then comes the nucleus, which is also. So a big cell with a big nucleus will be a LSIL cell. But is there any hyperchromasia in this? It's a pale
No, ma'am.
nucleus, as you said. Okay.
Yes, ma'am.
Now this
Ma'am.
large cell,
The cell size
cytomegaly.
is large, ma'am.
Yes.
Yes, ma'am. Eosinophilic cytoplasm is there, showing clearing, ma'am.
Yeah,
And
but it's
there
not
is only
two-third, but
mild
still it's increasing. Yes.
and only mild nuclear enlargement is there.
Yes. So when you have such cells and you did not have any classical coilocyte in the smear, what would you like to put this as?
Ma'am, pseudocoilocyte, ma'am.
Okay, but the cytomegaly is there, mild nuclear ATP, and this cavity is creating some doubt of LSIL. So would you like to call it an atypical cell and try to put it in the AST US category? Atypical squamous cells of undetermined
Undetermined.
significance. You are not sure. Quantitatively and qualitatively, these cells are very few. The classical cells are very few, and you just have a doubt that this could be a HPV infection. Okay, that we will come to later on. So we have to, now what is this? Dense keratinization and a dense
Yes, ma'am.
pycnotic nucleus. What do you call them
Yes.
as? Parakeratotic cells.
Parakeratotic cells.
Yeah. Now, here you have
Poilocyte.
yes, dyskeratotic cells and a collocytotic ATP. And now this cell is almost breaking down. And you see the color of the cytoplasm is very different in different types of cells. You will see some more of
Yes.
these. They are as if they are burnt out cells. So HPV cytopathic effects, they say that HPV burns out the cells. So you will get different colors of the cytoplasm, not exactly according to our definition. Now see this cell. There is a halo, but there
There
is
is
binucleation,
binucleation is also there.
cytomegaly, haloing of the cytoplasm, binucleation,
Yes, ma'am.
but there is no nucleomegaly. So if one
No.
of the features is missing from the classical features, we have to take a call in the end whether the smear in totality, whether it can be called as a smear of LSIL or it has to be labeled as QS. Sometimes you will have atypical nuclei, so you won't have the cytoplasmic features. Now here there is enough nucleomegaly.
Nucleomegaly, ma'am.
Hyperchromasia is not there. That could be because of the liquid-based preparation. Why this happens in LBC? Why do you get hypochromatic nucleus? What are we doing to the cells? We are putting them in a fixative. We are doing prefixation of the cell. And they generally
Yes, ma'am.
prefix cells.
And the hyperchromatic nucleus is due to air drying. The hematoxylin stains it towards the hyperchromasia, ma'am, in conventional preparations. But here the air drying artifact is reduced, so there might be hyper.
Yes. You do not have any problem of fixation in liquid-based preparation. Only thing that because they are lying in the fluid for some time, one is they are absorbing, imbibing the fluid inside them, and then ultimately they are taking a little paler stain as compared to the conventional smear cells. You are getting these atypical keratinized cells or atypical
Keratinized.
parakeratotic cells. This looks like a bad cell. This one looks like a bad cell, although I have not marked it. You are seeing all the features. Here you can see good nucleomegaly. But see how the cytoplasm is disintegrating. And it should catch your attention. When you're screening this, the slide under low power, it should catch your attention. Binucleation. And see here you are seeing these anucleate squams. You are simply seeing keratinization. This is also a large cell, collocyte-like cell with dense keratinization. And here these are some of the anucleate squams. One of them is having the nucleus, but it is almost going to lose it away. Here you are getting these anucleate squams. And why do we get that? So you are getting these just anucleate squams or disintegrating nuclei within them. See the color again is different shades it goes on taking because of the burnt out effect. Now, is the nucleus meeting all the criteria in this field?
No, ma'am.
No, ma'am. Nuclear enlargement
Still,
is
would you like to call them?
Nuclear enlargement is no.
So, is it still a pseudocoilocyte or it is a coilocyte? It is a coilocyte.
So,
See, the nucleus size is, it's not meeting the site, but it is little dense. And then it has all these other features. Now, what happens?
resinoid.
Yeah, it will subsequently become resonant. So, what are the different phases of HPV infection? One, you have the proplastic effect, and the other is the retroplastic effect. In the proplastic effect, there is proliferation of the nucleus. The nucleus is enlarging, the virus is using the nuclear and cytoplasmic machinery. So, everything is large, large, large. But in the retroplastic phase, everything is shrinking down. There is shrinking of the nucleus, there is shrinking and crumpling of the cytoplasm, and that's why sometimes the cytoplasm is also known as eggshell appearance. It is cracked and it is breaking down. So this is a phase where you are having the retroplastic features are starting. See now, again there is a nucleomegaly, very well defined halo and a sort of rectangular nucleus. See, these are all abnormal cells. So now how will we report this? Till I focus, tell me how will you report this?
Specimen type, ma'am, LBC. Specimen adequacy, ma'am, adequate for evaluation. Uh, General categorization, ma'am, epithelial abnormality. And in the interpretation, ma'am, low-grade squamous intraepithelial lesion, ma'am. And in the comment section, ma'am, reflex HPV testing is recommended, ma'am.
Okay, you want to do reflect. What was the age of the patient?
35 years, ma'am.
Yes. So do we do reflex HPV testing in women more than 35 years of age? 30 years of age. That is the cutoff. Okay.
Yes, ma'am.
This is the second slide that we would like to see. Now this is a slightly different slide. That was a very classical dirty slide where it was very easy for anyone to give a LSIL HPV cytopathic effects. Now here you are seeing, just go on seeing the features. They are there, but they are subtle. The nucleomegaly is not there, but that haloing effect is there.
Yes, ma'am.
Now there are some other features which are seen. If you are not seeing coilocytes, you do see many other features which can tell you that this could be because of HPV infection. Now this we call it as rafts and pearls. So you are getting a whirling of the sort of a pearl of atypical nuclei. We all know that we get squamous pearls, benign pearls in the smear, but here you are getting a pearl of atypical hyperchromatic nuclei. So they are generally known as rafts and pearls, and they come from the surface of the condylomas. Now see, this is another type of cancer. Yeah, but it's not very typical. Multinucleation in HPV infection generally starts from the center, and there only the nuclei separate, or either they become flower-like. We have seen some of them, but here the distribution of nucleus is all over the cytoplasm. Now see, these are again elongated abnormal nuclei. Here, this nucleus is also pretty abnormal, but the cytoplasm is not. So overall in this, see now, this pearl, it is again a pearl, but all the nuclei in this are hyperchromatic and of different sizes, different
Yes,
shapes,
ma'am.
and definitely it is belonging to HPV cytopathic effect. Now here there is some nucleomegaly, but it's very pale. The cytoplasmic features are not meeting.
Yes,
This multinucleation, this is a HPV preparation that I'm showing you. This multinucleation that I was talking about, it starts in the center. So these are very bizarre multinucleated cells.
ma'am.
Now this one, the nucleomegaly, is it more than 3 times the size of RBC? Or intermediate cell?
Yes, ma'am.
Yes. But there is no hyperchromasia, membrane is smooth, coarseness is not there. Either this is a degenerated nucleus or it is simply a benign reactive cellular change in the nucleus of the cell. And plus you can see the bar body over here. Can you
Yes,
identify
ma'am.
the bar body which is present on the
Yes, ma'am. Membrane bound. Yes, ma'am.
membrane? Here also there is slight dense. What is the criteria to call a bar body? How and where it should be present? What is the shape? Do you know everything about it? Okay, so you have to read it regarding it.
Okay.
But what has happened to this slide? What was this? There is no hallowing in this. So what is CIN1? Of course, in the Bethesda system, we do not separate the two. CIN1 and HPV cytopathic effect is combined in the LSIL category.
Yes.
But these are cells, they cannot be differentiated morphologically. But when you do not have coilocytes in the smear or all of the cells are of this type, then it is definitely still LSIL. But we do not write it as
HPV cytopathy.
CN1. No, we do not write it as CN1. You have told me the report perfectly, and you have also told in the additional notes that you are going to advise her HPV DNA testing.
Yes, ma'am.
By which, yeah. Now, see, now this is different types of clinically that you see. These are hyperkeratotic or warty lesions. They are present all over the vagina and also on the os that you are seeing. They are dense white. They are seen with the naked eye. Now, this is a micropapillary condyloma, which you can see, and after you apply, it is very very wet and moist lesions. And when you take smears from such lesions, you get abundant features, all the features you can see. And these are called as subclinical condylomas, which cannot be seen with the naked eye, and only when you apply 5% acetic acid, they become white in color. They have sharp margins, and then you know that the patient is having a condyloma. These are the histopath pictures of this case. And if it is a CIN1, you are going to get all the features in the basal layers. We won't go into the details of that. But with a condyloma, the features are more often present in the superficial layers.
Ma'am,
Yes.
there are a couple of questions.
Yeah, you can take.
Someone has asked that only nucleomegaly and paranuclear clearing will suffice to call it as coilocytic change, or we need a irregular resinoid membrane.
No, as I told you, there are proplastic effects and retroplastic effects. In the proplastic effects, you will have an enlarged nucleus. So nucleomegaly is there. By definition, it has to be more than 3 times the size of intermediate cell nucleus. And if the perinuclear haloing is also enough, occupying almost half or more than the 2/3 of the cytoplasm, that is enough to call it a coilocyte. Resinoid and nucleomegaly both won't be there. Resinoid nuclei are shrunken nuclei. They'll be smaller. They can of course be very large also, but they'll be having irregular nuclear membranes.
Ma'am, another question is L cell can be seen in superficial cells only or can be found in intermediate or parabasal cells?
I think that's a very basic thing that you will get. LSIL is a disease of mature cells. HPV infection occurs in the mature squamous cells, intermediate and superficial squamous cells. Parabasal cells, no. When you start getting abnormalities, it is a whole set of differential diagnosis and many things come into play. Okay? So,
Thank you, ma'am.
Anna, Sumit, I will do. My voice is echoing.
Yeah, Dr. Kamal.
Yeah, I'll take up one classical HSIL case.
Sure.
Then we can slightly, okay, I'll complete with this one also. And then we'll take a call what to do, okay? If it's getting late for them. Now, this is the case 6. Who will do it, Shehnaz?
Yes, ma'am.
Tell me. 38-year female.
Yes, ma'am. 38 years female, previously reported as SQS.
Now tell me the full form of this SQS.
Atypical squamous cells of undetermined significance.
What does it mean?
Ma'am, this is when the nuclear size, nucleomegaly is present, but nuclear size is enlarged up to 1.5 to 3 times of the normal intermediate cell nuclei. And there is no nuclear membrane irregularity. And no coilocytes also will be there. In that case, then in that case we will report it as SQS, ma'am. Also,
Yes.
in case of LCIL, when not many criteria are present and we are not sure to report it as LCIL, we can report it as SQS, ma'am.
Okay. So when you have the quantitatively, the abnormal cells are very few, just 1 or 2 cells are very abnormal and they are having all the features of LSIL, but they are very few. So quantitatively you have few abnormal cells, or qualitatively you don't have all the features of LSI. In that case, you can use this category.
Yes, ma'am.
Now, in this history, they have told previously reported as Ask US.
US. Yes,
So the slide must have gone to some pathologist who was in doubt and just left it as Ask US. Let us see what are the criteria. Now, what are you seeing this? Now, this here is a wart. Warty
Yes,
lesion. It
Warty
has a
lesion.
hyperkeratotic surface, the clinical picture that I showed you.
Yes,
And when you can imagine that when you're taking a smear from such a surface, you're going to get such cakes of A nucleate squams in the smear. So this is one feature. Now these warty lesions, they have a parakeratotic surface also.
Yes, ma'am.
Yes. So you have this histopathologically. What is parakeratosis?
Parakeratosis is nucleated superficial keratin layer.
Nucleated miniature
Retention.
superficial squamous cells.
Yes.
So they are sort of compressed superficial cells, but their nuclei are dense hyperchromatic. You have benign parakeratosis and you have atypical parakeratosis. So here you can see atypical parakeratosis. Why? Because there is anisonucleosis.
Yes, ma'am. Anisonucleosis, nuclear overlapping is also seen, ma'am.
Yes,
And
and
the
you are
cytoplasm
having abnormal shapes also.
shape. Yes, ma'am.
Now, this is again a parakeratotic plaque over here.
Yes,
And
ma'am.
here at the periphery where the cells are dispersed, what all you are seeing? Come on, say.
Parabasal cells we are able to see, ma'am. And
No,
some stripped nuclei.
no, they are not parabasal cells. They are all matured cells. But we said they are compressed, dense, superficial and intermediate cells which form this parakeratotic layer. See, the nuclei are abnormal. Here you are seeing a large nucleus, binucleation, dense hyperchromasia. Here you are seeing an enlarged nucleus, this one with irregular nuclear membrane here also. So there are nuclear abnormality and probably that is coming from such a surface. Now when you have a surface like this, you can have any type of lesion beneath it. You can even have a high grade lesion. So finding these features in the smear is very risky and you have to take cognizance of that because it can camouflage a very high grade lesion beneath it. So these are the features that we are afraid of. Now this is dyskeratosis. What is dyskeratosis? This also is dyskeratosis.
Dyskeratosis is abnormal keratinization, ma'am, of the
In deeper cells.
in
Now
the deeper
deeper
cells.
cells normally they do not keratinize.
No.
We know that only they keratinize when they become mature. So even if they are parabasal or basal type of cells and you are seeing orangophilia of the cytoplasm and keratinization in the cytoplasm, they are called as dyskeratotic cells. And they again come from a HPV infections and they can also come from high-grade lesions. What was the slide number for this? Okay, I haven't written.
On slide 15, ma'am. Slide 15.
Acha, in your this it is there, na? Okay, okay.
Yes,
Good. Yeah, that's I'm trying. Now, this slide is particularly for atypical parakeratotic cells. Okay. Now, what are you seeing this? Here, there is slight nuclear enlargement.
Yes, ma'am.
It's a mature cell. There is nucleomegaly, but it is not going beyond 3 times. Okay. Here again, you are seeing.
Nucleomegaly is there, ma'am.
Yes, there is nucleomegaly. It's a mature cell. But in addition to that, you are seeing these parakeratotic small cells with dense cytoplasm and a dense hyperchromatic single cells. Now, as against a conventional smear in LBC preparation, as we said, they will be because of the vortexing of the cells, they will be separated. So getting stacks of them will be a little difficult, or sometimes you can see. Now, in this stack of cells, You can see some nucleomegaly, and here you can see these miniature squamous cells. Yeah. See, I want to show you these types of parakeratotic dense, hyperchromatic nuclei, similar to what we saw in our conventional smears. What do you call this?
Stereoractic.
These are very small, deep basal cells. Probably this is not the.
For case 8, ma'am, slide number 19 was there.
For,
Which was
for
for
case
case
8.
8, ma'am. Yes, ma'am. Slide 19 was there, ma'am.
Oh, that will go fine. That is it. But this case was little. So I think what I wanted to show you here was these anucleate squams, which I think we saw in the previous HPV slide. And then these parakeratotic cells that we wanted to see, this keratosis will subsequently come in other slides. Now, how will you report it? Come on, make the reporting thing by heart in your mind. Specimen type?
Specimen type liquid-based cytology, ma'am.
Mm-hmm.
Specimen adequacy, adequate for evaluation. Endocervical zone absent.
Component not seen.
Not seen, ma'am.
I haven't shown you.
Yes, ma'am. General categorization, squamous epithelial abnormality.
Epithelial abnormality, squamous epithelial. Okay.
Yes, and in interpretation result, high-grade squamous intraepithelial.
No. Where we haven't talked about high-grade lesion as yet. We are still dealing with the low-grade squamous intraepithelial. LSI, dyskeratosis, parakeratosis, hyperkeratosis. These are all features of low-grade lesions. And in additional notes, what was the age of the patient? 38-year-old.
38 years, ma'am.
Yeah. So we will advise a HPV DNA test if she can afford it. But by and large, what is the pattern? You need to follow up the patient, a repeat smear after 6 months and after 12 months. If she is negative, she goes in the routine screening pool. So these rafts and pearls I've already showed you, and these features, they are called as non-classic changes of HPV infections. So you get cell plaques, you get hyperkeratosis, that is anucleate dense keratinized squams, you get parakeratosis, and you get dyskeratosis. So we saw these rafts and pearls, and I will show you in a subsequent slide. You get clusters of koilocytes. They are sticky plaques of koilocytes. That is what is called. And you get these other features. We have seen these parakeratotic cells also. Now these are the histopath pictures of the same. Now we'll come to the, what is more important is what are the benign conditions that cause reactive cellular changes which mimic HPV infection or an LSI. That we have to, the differential diagnosis that we have to discuss. Coming to case 7, Chinmay, bataiye.
30 years old female, ma'am, complaining of blood-stained white discharge since 6 months, itching in the perineum, history of previous treatment for similar complaints.
So don't you think the history is for slightly longer duration?
Yes, ma'am.
And she has taken, a lot of treatment, and still she's come with symptoms, and we are taking a smear from such a woman. Just now remember the slide 13 and 12. Now what are you seeing here? Nuclear ATVA.
There are yes, ma'am, with perinuclear halo, ma'am.
But now all these are uniformly present in most of the.
Yes, ma'am. In all these cells, most of the cells, ma'am.
Is the diameter of the perinuclear halo enough? Even
No,
if there is
ma'am.
hyperchromasia and smudging? No.
No, ma'am.
Here in
It
this,
is not occupying the area more than two-third of the cell cytoplasm.
in this cell, it's slightly more atypical as compared to all of them. है ना? The nucleus size is big, but it is smudged. In a smudged and a resinoid nucleus, the criteria of the size slightly you have to uh, interpret according to other features of the cytoplasm and the other features of the nucleus. Now, so you have this. Now, what has happened to this cell? There is a halo.
Yes, ma'am.
Yes, ma'am.
Yes, there is hyperchromasia, but everything looks like as if it is degenerating. And
Yes, ma'am.
another important
The
thing,
nuclear.
there is nucleomegaly, there is hyperchromasia, and this cavity is big enough, but it is not sharp enough. So it is as if a part of the moth-eaten appearance of the cytoplasm because of trichomonas vaginalis. Now here in the, sorry, these are the TV that you are seeing.
Yes, ma'am.
Three TV bodies. Here you have nucleomegaly, you do have cytomegaly. See the perinuclear halo, it is so frayed out, it's not very sharp. So these are actually the pseudochondrocytes. And these are the reactive cellular changes associated with uh, TV infestation. Okay, mimicking coilocytes. Now, in this whole field, there are only two cells. One has a very dark and tell me what type of
Hyperchromatic.
nucleus is
Resinoid pigment.
Yes, dark, shrunken, smudged nucleus. And the other nucleus is really large.
Vesicular chromatin, ma'am. Open chromatin.
No, no, we
Is
won't call
there,
it vesicular, but the chromatin
ma'am?
is abnormal. And here you have a wire looping perinuclear halo. What has happened to this cell? But what is the point in this? All of the cells are very absolutely looking normal. So when you get only such two cells, but they are significant, then you need to report them as in the SQS category. What has happened to this cell? Cytomegaly, single cell. There is no halo, but there are two nuclei which are large and of abnormal shape. They are hyperchromatic also. There is membrane irregularity also. You can see here.
Yes, ma'am.
So this is also a single cell which is abnormal in this whole gamut of cells. Now what you start seeing, what are these filaments?
These are candidal
Pseudohyphae.
pseudohyphae.
Yes, they are candidal filaments. Now here there is some amount of nucleomegaly,
Yes, ma'am.
Yes, ma'am.
atypical nucleus. Here again there is nucleomegaly, but it is a very pale nucleus, very regular. Okay,
Yes,
what are
ma'am.
these?
Shish kebab
Fish
appearance,
kebab
ma'am.
appearance.
Perfect. So you have these fungal filaments on which the squamous cells have been skewed up. This is Jones-Mary's stain that we had tried in a project. The inside the whole this skewed up squamous cells, you have these filaments that are standing out. Again, you are having these filaments over here. Now, when you are having these pathogens present over here and you are having the atypical nuclei, what are you supposed to do? And how much is the atypical? That is what you have to gauge. Now, what is happened to this nucleus?
Binucleation is there.
Binucleation is there.
Hyperchromasia is there.
Nuclear mem
Yes,
nuclear membrane is somewhat regular now. There are
it's
no
somewhat
membrane
regular,
irregular.
very slightly irregular, but hyperchromasia and size is also significant. Now, this LBC smear, what is this? Does this look like a reactive nucleus to you? And this looks like a nucleus of LSIL. This is a very difficult zone where you need to separate the reactive nuclei from the nuclei of the LSIL, and all our efforts would be. Now, what has happened in this cell? This is a cytomegaly, enlargement of the whole cytoplasm or the whole cell. These are all
Yes,
normal
ma'am.
sized? Yes?
No, ma'am. Yes, ma'am.
These
The
are
other ones are normal sized. The upper one is having cytomegaly, ma'am.
yes, and the nucleus is also smudged, but there is no megaly by definition. Okay, 4 to 6 times. This is also a slightly, this is a normal size cell, but there is a hyperchromatic nucleus. Now, what was the slide number?
13, 12.
13 and 12. 13 and 12.
I'll just look it up. So this is 13 is here with us. What is the cell ball? You are not able to say whether
Glandular cell.
glandular cell ball. It is a glandular cell ball. You are not very sure what it is. Now, what is this on the pointer?
TV bodies, ma'am.
Trichomonas.
Yes.
Vaginally.
Yes. Here now you are having this dense eosinophilic cytoplasm, hyperchromatic nucleus, slight enlargement of the nucleus. We will go on seeing these nuclei and then decide where in which category you want to put it. There is definitely TB infestation. There are benign reactive cellular changes associated with TB infection, all the 4 or 5 of them. But in addition to that, some cells and nuclei are crossing the definition of reactive cellular changes. So we have to decide whether along with TB there is LSIL also, yes or no. So that is the dilemma. Here what is happening? Dense, smudged nuclei, but not enough ATP. Again over here, dense, dark, slightly enlarged. This one also, because when we say a smudged resinoid nucleus, then it applies everywhere, whether or not TB is present, yes or no, but it does apply. Here there is cytomegaly, yes or no?
Yes.
But there is no nucleomegaly, and the halo is also just 1/3. Now this cell, this looks abnormal, atypical.
Halo,
Yes,
halo
no.
is
Perinuclear
not.
halo is there, ma'am. But the cytoplasmic margins are not clearly seen.
Halo is also
So
not
it
covering
can be a
As
degenerative
large.
cell.
Yeah. So now here you have a bigger halo in this cell. And here you have a more atypical cell over here. Now what are you going to do in such a situation? Would you try to attribute all these features? Here you have got a pus ball that you can see in TB. Here there is a TB. Would you like to attribute all these features to reactive cellular changes, or you feel that you want to report it as QS? This cell, it looks abnormal to me. These nuclei, they are large, pale. So what do you do in this? Here comes the real dilemma. When there are classical features, there's no problem. Anyone can close eyes and report classical coilocytes. So all these pseudo-coilocytes, you want to call them, or you just want to call them atypical cells, what you want to report them. So how will you frame your report? Come on, specimen type?
with basic
LBC, ma'am.
Yes. Adequacy?
Adequate for evaluation, ma'am.
And?
cervical zones.
Endocervical cells
Not
absent.
same.
Yeah. And but how many of them should be there? What is the number?
10 to 12
10.
well preserved endocervical cells should be present.
Okay.
Or
Now,
squamous
what
metaplastic
category?
cells.
Yeah. What are you going to do about this category? You want to put it as NILM? You are going to put in your notes and interpretation trichomonas vaginalis seen.
Identity.
Yes,
Yes, ma'am.
so see, if you feel that those abnormalities were enough, and some of them we did see enough abnormalities, you can report it as QS. But you need not advise a HPV DNA test. First, ask for a repeat smear after treatment. Maybe all these changes, they will revert back after treatment of infection. The nuclear ATPI will go away. The infection will be treated. Candida is gone. TB is gone. And then the cells, they come back to normal. But if they are really abnormal, they will persist. And that is why a repeat smear after 6 months will help in taking a call or a decision whether we should do a HPV DNA test in such patients or not. Okay?
Yes, ma'am.
Now, these are the differential diagnosis of perinuclear halos apart from what we saw with TB infestation. Physiological, the navicular cells or the intermediate squamous cells loaded with glycogen and slightly abnormal nucleus, you start doubting whether this is a coilocyte or not. So here also you can see, here you can see glycogen laden, but then you have to strictly apply the nuclear criteria. We have seen all the reactive and inflammatory changes associated with TB infestation. Then you have atrophic epithelial cells, we'll see that, and immature squamous metaplasia. Now, these are immature metaplastic cells. As I was telling you right in the beginning, that you can have a two-tone cytoplasm, pale inside and dense outside. That also sometimes gives you a appearance of pseudocoilocytes. Now, this is another, I was talking about a plaque of coilocytes, or sticky plaques you call them, but none of the cell is meeting all the definite criteria. There is haloing, significant haloing. There is some amount of nuclear atypia. There is, these interpretations are very subjective, but here you can safely report it as ASC-US. Similarly for these cells.
Yes.
Now, this is a degeneration type of vacuolation. Again, pseudocoilocytes associated with degenerating swollen nuclei, swollen cytoplasm, logged with water. Now, these are the metaplastic cells we were talking about, pseudocoilocytes, cytoplasmic vacuolation type of appearance, and you have the binucleation, etc. Okay, now coming to this case, Shanaz?
Yes, ma'am.
48-year-old
48-year-old woman with prior abnormal cytology.
Okay. What are these cells? A very straightforward case.
Yes, ma'am. Ma'am, these are parabasal-like cells, ma'am, present in sheets, and they are showing high NC ratio and hyperchromatic nuclei with prominent irregular nuclear membrane.
Yes, here you can appreciate the notches in the nuclear membranes.
Yes, ma'am.
Irregular nuclei, dense hyperchromatic nuclei. They are not mature cells. They are definitely immature type of cells or metaplastic type of cells. How do you recognize a metaplastic cell?
Ma'am, a metaplastic cell will have the cytoplasmic projections
Yes.
that will resemble the
Cookie
stomach
cutter
cells.
type of
Yes,
appearance. Cytoplasm will be dense,
dense.
and they can have frayed margins, giving a cookie cutter type of appearance. What is this cluster known as? Syncytial cluster?
Syncytial, yes, ma'am. Yeah,
Please.
yes. Indistinct cell borders are there, ma'am. Only
Yes,
nuclear.
so in a common cytoplasmic background, you have multiple nuclear lines. So this is more syncytial as compared to this. Here you can see some cytoplasmic margins.
Yes,
So what will you call it then? A flat sheet of cells.
sheet of cell, yes, ma'am.
But there is a lot of anisonucleosis, variation in size, shape,
Irregular
chromasia.
nuclear membrane, yes, ma'am.
Yes, irregularity in as if the nuclei are fitting each other inside the sheet or in the syncytium.
Yes.
Again, you have these irregular membranes and large hyperchromatic nuclei. So this is an out and out case of
HSIL.
Yes, sir.
Now, what are these cells? These are HSIL cells, but how are
HSIL
they
cells, ma'am.
different? Yes, but are they different from these cells? From these cells? They are absolutely
Yes, ma'am.
round. Absolutely round. This is the cell of carcinoma in situ. Although we do not separate them with the Bethesda system, we club it under HSIL only.
HSIL.
But these are absolutely immature round cells with hardly any cytoplasm. And then they are coming from a CIN3 type of a lesion. What is this? I've already written on top, keratinizing dysplasia.
Yes, ma'am.
What is this entity by itself?
These are dysplastic cells with keratinization, ma'am.
And where you cannot segregate them into either HSIL or HSIL. So here you cannot segregate them because all of them are having abundant keratinized cytoplasm and very bad nuclei. And we have seen that we can get very atypical keratinized cells in LSIL also, and they can also be seen in HSIL. It's a variant by itself, and you have to just label it as keratinizing dysplasia. Now, for this, which case do we have? Tell me which case was I had written on top?
Case 8, ma'am, slide 19.
19. Now it is very common to have combination of lesions. It's not as if that when you have HSIL you won't have LSI. Now what are you seeing? This is the liquid based preparation.
Yes, ma'am.
And we will see what are the differences. You get more of single cells, less of syncytial clusters. You do get, but they are lesser. Now see, we were talking about dyskeratotic cells.
Yes, ma'am.
Highly keratinized deeper cells of the shape of parabasal cells. So this is a dyskeratotic cell. This is an abnormal cell.
Yes,
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 or no?
ma'am. Yes, ma'am.
But
With high NC ratio and
hyperchromatic.
nuclei, yes, ma'am. Nuclei have hyperchromatic but indistinct nuclear border.
Membrane. So that is a problem of LBC. It makes it very difficult sometimes to interpret the single cells. And they, because they are lying in the fluid for a long time, they do not flatten out on the slide so easily as when we prepare a conventional smear. This you feel sometimes this is an artifact or something. It may not be a HSIL cell. This is a pretty abnormal cell. See,
Yes,
the
yes, ma'am.
irregularity of the nuclear membrane. So this is a typical HSIL cell. But now in this slide, you have lot of cells of LSIL also. And then you have these, what are these?
Pseudohyph.
Yeah, candidal filament, pseudohyphae.
Yes, yes, ma'am.
But this nucleus, you see, this cytomegaly, irregular nuclear membrane, this is a classical LSIL cell.
Yes, ma'am. More than 3 times.
Yeah, normally what happens as the lesion progresses from CIN1 to CIN2 and 3, although the HPV has induced that lesion, the morphologic features, they take a back seat. You no longer you can identify coilocytes or LSIL type of cells. But many a times they do remain there, and then you can in a slide you can see both the features of LSIL and HSIL. So this slide is example of that. And all these abnormalities are way beyond if you want to attribute it to reactive cellular changes. This is just a secondary finding when these significant primary findings are present. Now here there is a syncytial cluster. And then we have to try to identify cells. Now syncytial clusters also, they become very rounded up, dense, thick. These are all abnormal cells jutting out from the periphery, but still not, they could be HSIL cell in the background of what we saw before. See this LSIL cell? All
Yes,
of
ma'am.
you, Nupur, Aparna, Deepmala, Shenaz, everybody
Yes, ma'am.
appreciating, no?
Yes, yes, ma'am.
Yes,
They
ma'am.
need no description. Now these are cells of HSIL type.
HSIL, yes.
Hardly any cytoplasm. This also.
Yes.
See how bad the
Yes.
nucleus is.
Yes.
Irregular. But it really requires some practice to identify these cells. Now, what are these cells? There is maturity of the
LSI.
cytoplasm. Yes. You want to call them LSIL?
These are nuclear enlargement is more than 3 times,
Significant.
ma'am.
Yes. And all other features are there, but I want to show you something else over here. See this cell?
Yes, ma'am.
Huge cytomegaly, binucleation is there.
Binucleation is there.
Again, another very typical
HSIL.
HSI cell.
Yes.
So this, I want to show you. This is again dense cytoplasm. Now here you are seeing some nucleoli inside this. Now, is finding nucleoli very safe?
Yes, ma'am. Nucleoli can be there
Nucleoli
in
can be
reactive
present
change
in
also.
reactive cases also.
But
In
when
case of PAPS,
we are finding that these cells are all HSIL cells and you are seeing nucleoli, what you want to call them. When does that happen? Now, when you are seeing a lesion of HSIL, you are not sure whether or not there is invasion. Hello?
yes, ma'am.
Yeah, so you don't know if invasion is there or not. Invasion has to be identified in the smear with the tumor diathesis that you get. So we are not seeing any tumor diathesis over here. So in microinvasive carcinomas, as soon as there is microinvasion, you start getting small nucleoli, but that happens only in around 20 to 30% of cases. And then you can suspect. Somewhere in the smear, I would show you some tumor diathesis. Now see, this is a plaque of those coilocytes that we were,
Podocytic cells.
that sticky plaque that I was talking about. You do get single coilocytes, but you do get such plaques also. See, this is a whole sheet of abnormal cells. Now, I would like to call these cells, although we would still label it as HSIL, these cells are showing features of CIN2. According to us, when we used to report this terminology, these are the nuclear and cytoplasmic features, some amount of cytoplasmic maturity, and the nucleus is very abnormal, conforming to the features of HSIL. So these are cells of CIN2. So you have all the features in this slide, CIN1, 2 and 3, progressively seen. It must be a huge lesion with different types of areas, and all the areas have been scraped. See this plaque of abnormal cells?
Coilocytes.
Yeah. So again, cells of LSI. Now these are very deep, small, basal, parabasal type of cells with features of HSI. Now how will you report this? Come on, it's easy to report now.
Ma'am, specimen type liquid based pap smear.
Yes.
Then adequacy, it is adequate for evaluation. Endocervical cells not visualized. General categorization, squamous epithelial abnormality.
Yes.
And then in interpretation and result, we will label it as HSIL.
First as HSI.
HSIL.
First as the highest abnormality to be reported first. Okay. Then also features of
LSIL as a coilocytic
cytopathic effects of
HPV
LSIL seen in the form of coilocytes.
Yes.
Now, would you want to do a HPV DNA test in this patient?
Because HSIL cells are present, we can go for colposcopic and biopsy for that patient.
We can or we may not, but the standard protocol is that when you have HSIL, she directly goes for
colposcopy and biopsy.
And we know that majority of the cases, 90% of the cases are because of high risk biopsies. And see, this is how the lesions look after acetic acid and after Lugol's iodine. This is the biopsy. And in colposcopy, you should know these features. You have this mosaic pattern, you have these abnormal angiogenesis and capillaries going up to the surface and creating these punctations. In LSIL, you have very fine punctations. In HSIL, you have coarse punctations, and you have this tiled appearance, and the tiles are of uneven sizes, and punctations are present even in the center of the tiles. So this is what, when we do colposcopy, we do see all these features and try to differentiate. These are the persistence and regression rates. I think you can read about this. Coming to the case 9. This is very important, although we are now at the fag end, getting a little tired. I know you must be tired, but we come to another category where as QS we had for LSIL, now we have the ASK-H for the when you are in doubt whether this is HSIL or not.
Yes,
what are these cells?
These are metaplastic cells, ma'am, which are showing nuclear enlargement.
Yes.
And also nuclear irregularity we are able to see. In one cell, we can see binucleation.
Here. Okay. You're perfectly right. But I want you to talk about this cell now. What is this cell?
This is metaplastic cell, ma'am, which have
more mature. Okay.
Yes, ma'am. Mature metaplastic cell,
Huh.
which have nucleomegaly, ma'am.
Irregularity, yes.
Yes, ma'am. But
Hyperchromasia, coarse chromatin.
yes, ma'am.
Now, this looks metaplastic and the nucleus is sufficiently enlarged. Here also it looks, the maturity of the cytoplasm is good. So would you like to call a cell of LSIL, or you want to still, because the ATPI is there in an metaplastic cell, you want to call it as a HSIL cell, but ASC-H cannot rule out high
Yes, ma'am.
grade.
SKH, I would like to.
Or would you like to put it as SQS in a metaplastic cell? So now these are the subtle categories, intermediate categories, intermediate interpretations, subjective variations, but definitely when so much nuclear abnormality is there, and sometimes it becomes really to categorize it in which to put it, whether it is LSIL or HSIL. So we'll try to sort this out. Now this is the LBC preparation. See the nucleomegaly.
Yes, ma'am.
More mature cell, it is not a, it is up to the size of an intermediate squamous cell. Cytoplasm is very dense, like that of one of metaplastic cell.
Metaplastic
So
cell.
what I want to point out here is all the features of that icon cell that we call parabasal, intermediate, superficial, basal. All the features are classical features of the icon cell are not there. They are all mixed features. And then when you learn the classical thing that bigger cell, bigger nucleus, LSIL, smaller cell, larger nuclear, high NC ratio, HSIL. So these criteria don't fit over here. Now again, there is a sheet of cells over here in LBC preparation. Now at the periphery, you can try to identify, but they are all spindly. And then there is stratification of these cells. So definitely they are squamous.
Yes, ma'am.
Now this sheet, now is this reactive changes associated with inflammation and repair, metaplastic cells with reactive atypia, or are these HSIL cells? We'll try to see these in the, now what are these?
Here, ma'am, these 3D ball clusters are present, which can be endometrial cells, because at the periphery of the cluster we can see very small sized round regular nuclei. So this can be endometrial cells.
So basically they are hyperchromatic crowded
Groups.
Crowded
Yes,
groups.
ma'am.
of cells. And when we have to sort it out whether they are endocervical, endometrial, or squamous, or glandular, what they are, because they could turn out to be anything. And then we have to do a lot of clinical correlation. Again, here what are you seeing? These are syncytial clusters.
Yes, ma'am.
So when you have when you have a HCG, that is hyperchromatic crowded group, first you have to decide whether it is glandular or squamous. If it is squamous, generally the cells have a flattened surface, like here you are seeing this is flattened, and beneath the flattened surface or in the center you have whirling of the nuclei, and this is a classical feature of squamous lesions. Here you see. So it could be a high-grade squamous intraepithelial lesion. But unless it is dispersed and you see additional features with such clusters of cells, you are unable to say, and then you have to report them as HCGs or ASC, cannot rule out high-grade lesion. That is the interpretation that you have to put. These are all same. Now another occasion is when you have these single abnormal cells. They are also called as litigation cells. You just have one single abnormal cell hiding behind the normal cells. So quantitatively they are highly, I mean they are very few, but they are really very abnormal. But you feel that you should not report immediately as HSIL. So then you can use the category of ASC.
SKH.
Atypical squamous cells cannot rule out high-grade lesion. Now again this one, here you have a keratinized cell.
Yes.
And with a high NC ratio, here you have a binucleate or two cells with a high NC ratio. So they are hiding here and there, and when if you're not very confident, you can report it as sketch. We'll just try to see one of them. What number was written?
15, 16, ma'am.
is a little difficult and tricky. So this was the slide which we were confused. See, these are the cells that you see in liquid preparations. They're very small, round, dark, where you cannot clearly see the nuclear membranes, or you cannot assess the texture of the nucleus or the chromatin. But then when you see such cells, this is definitely atypical. What do you call this? Like swan's neck abnormality. Yeah, tadpole type, and there are different names. But see the high NC ratio, hyperchromatic nucleus, very large nucleus, and trying to become a tadpole-like cell. So then when you see such cells, you try to report them as ASK-H with all other abnormalities that we were trying to see before.
Yes.
And which other was the number? 15 and?
16,
15, 16.
16.
Upfront, these cells, they again, the nuclear features are not very clear, but they do look atypical. Very dark, hyperchromatic nuclei, and majority of the abnormalities are seen in metaplastic cells. And in this slide, you have these cells of LSI. So even if you are not able to see these dark, the nuclear texture, and this is, I think, a very difficult zone of LBC, because we also face a lot of problems, and if there is overstaining sometimes, if Salim is there, he can comment on this if possible. But here you are seeing very clear-cut LSIL cells. You appreciate it?
Yes.
So definitely there are very high chances that the abnormalities that you are seeing in these single cells could be cells of HSI. Now, how will you report this? That is more important. What message will you give to the clinician? Do you want to call it only LSIL, or you want to go overboard and call it HSIL, or you are doubtful that LSIL is there, but you want to report it along with ASK-H? What do you want to do?
ASK-H, we can report this.
Yes, LSIL along with ASK-H would be a better interpretation rather than going in for directly HSIL, because you are not very sure. Some of them, there are a lot of abnormalities, but definitely there is LSIL also. Now this is a metaplastic cell, and abnormalities in a metaplastic cell are generally, but this is, I had showed you pseudocoilocytes. This could be just a reactive change. Now this, again, it's a cell on cell. So you have these dark cells where, but you have these, definitely you have these LSIL cells. See? Sometimes you can just call them cells of repair, atypical repair. See, you have this two-tone cytoplasm, and you're not sure what are they. Okay, so now we try to just go to the last case. What are you going to report it, Bolo?
Liquid-based cytology, ma'am. Then adequate for evaluation. Endocervical cells not seen. General categorization.
But you did see a lot of metaplastic cells?
Yes, ma'am. Endocervical cells with
See, you have this two-tone cytoplasm, and you're not sure what are they. Okay, so now we try to just go to the last case. what are you going to report it, Bolo?
Liquid-based cytology, ma'am. Then adequate for evaluation, endocervical cells not seen. General categorization.
But you did see a lot of metaplastic cells.
Yes, ma'am. Endocervical cells with presence of endocervical
Transformation
cells.
zone component that does come in the
Yes.
TZ component.
Yes, ma'am. Then epithelial abnormality, and also in other, we will mention the hyperchromatic crowded groups, ma'am.
No, LSIL, you will definitely, there is LSIL.
Yes,
Yes.
LS.
So epithelial abnormality squamous, then you will report it as LSIL, and the second thing you'll report as
SH.
H.
H. And then what will you advise? You have to convey to the gynecologist that you are not confused. You are very clear that there is ASCAD, they must do colposcopy. Advise a colposcopy. Coming to case 10. Come on, read the history. You can do it. Aparna can do it.
Aparna is there?
Nupur?
I think we can see Shanaz and Chinmay now.
They have left the
Shilpa.
screen. Don't tell me I'm only sticking around.
No,
Okay,
no,
come on.
there are actually, I think they have audio video issues.
Okay, come
Check
on,
the-
Chinmay, you tell us. Read the history.
Case 10, ma'am. 55 years old female, ma'am. Complaining of postcoital bleeding. On per speculum examination, anterior lip of cervix flushed with vagina. Per vaginal examination, cervix feels hard.
So all these signs, symptoms and signs, what do they indicate towards?
Neoplastic etiology, ma'am.
Invasive malignancy, it is.
Invasive malignancy. Postcoital bleeding, again, a very high grade lesion or microinvasion does that. Anterior lips are flushed with the vagina. That's a classical sign of cervix being pulled up because of invasion, and then you cannot feel them separately, and then cervix is feeling hard. That is again another sign of invasive malignancy. What are you going to get? What are these? It's a syncytial cluster.
Yes, yes, ma'am.
Yes, ma'am. With marked nuclear pleomorphism, ma'am.
Yes. Still the nuclei pretty round. Micronucleoli you can see.
Yes,
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 ma'am.
ma'am.
Micronuclei. So
How many?
definitely microinvasion or more invasion is there. And you can see some necrosis around the cells.
Yes.
So it's in a, this syncytial cluster is lying in a dirty background. What are these cells? Now, what such a cell is doing in an invasive malignancy, is this a LSIL cell or it is a part of squamous cell carcinoma? Okay, now this is a liquid.
Bizarre cell, ma'am, from squamous cell carcinoma.
Yes, you do get bizarre cells in squamous cell carcinoma. Once there is invasion, they take up their phenotype and they start differentiating towards the squamous phenotype. So you have dense cytoplasm, dense hyperchromasia, and other features. You start identifying them as squamous cells, but here they are highly immature looking cells. Now this is LBC preparation. See how dirty the background is.
Yes.
And you have these keratinized
Pulses.
cells. This is a conventional smear. What are you seeing here?
Tadpole cells.
Tadpole shaped cells here, I mean.
This one you want to say?
The above one, ma'am.
Yeah, this fiber cell, I'll show you plenty of them. But these are all round immature cells with necrosis in the background.
Yes.
What do you call this as?
Tumor diathesis.
Diathesis.
Tell me what are the components of tumor diathesis?
Necrotic debris, ma'am. Fibrin strands and hemorrhagic.
Fibrinous material.
Fibrinous material and hemorrhagic and hemorrhage, ma'am.
But what will be the type of blood that is used that you see? Hemorrhage. Old
Yes, ma'am.
or fresh blood? What do you see? You should see lysed RBCs. That's one of the important criteria. Old blood is seen, lysed RBCs are seen, because fresh blood you will otherwise also get when you take a smear, because the lesion is bleeding on touch. The cervix is very bad and unhealthy. So you are getting all. Now in LBC, how does the tumor diathesis look? What was the case number? 20.
Case number was
24. It's the last case. How does
Slide
it?
24, ma'am. 24.
Yeah, I'm getting it. Tell me how the tumor diathesis looks in LBC. What is the description of tumor diathesis? All that you're seeing
The
here.
dirty background.
Okay. It is a dirty background. It is necrotic material and cytolytic material mixed with inflammatory cells and lysed blood. But you are processing the sample. You are cleaning it up. You are subjecting it to the DG reagent. And the DG reagent, what does this reagent contain? You have to read up this, okay? Read up what are the different steps. The DG reagent is a very high concentrated sucrose solution to my knowledge, and that holds up the necrotic material, mucus, pus and everything. And the cells, they have a lighter weight, and so they settle down at the bottom in the form of a button. So normally in a LBC smear, you're not going to get that much of dirty background and tumor necrosis. Now, either this is a processing problem or there was too much of the necrosis, less cells, and that is why we are getting it all over. Otherwise, in LBC, it is called as clinging diathesis. So you just have necrosis along small groups of cells clinging to the cells. And it's sometimes really difficult to identify clinging necrosis. And the slide absolutely looks like a high-grade lesion slide or a keratinizing. You can, if you do not have this necrosis, you can even call this as keratinizing dysplasia. All these cells are keratinized and they have highly abnormal nuclei. See these fiber cells, very long tails of cytoplasm on both sides and a dirty necrotic background. You can see many more such cells over here. See all these cells. Abnormal dense hyperchromatic nucleus like you get in any FNAC of squamous cell carcinoma that all of us have seen number of times. Easy to diagnose. But then where you get well preserved cells, you should try to see all the features. These are those spindly squamous cells with highly abnormal nucleus and the diathesis behind. And then such cells with high NC ratio. I'm not talking about these because these are those artifactual cells where you cannot resolve things. This one I'm talking about. Dense hyperchromatic nucleus, coarse chromatin and this keratinized cells. So you have all features of squamous cell carcinoma in this. Here you have this stack of cells over here, stratified, and inside you can see these keratinized cells. So this is a classical squamous cell carcinoma slide. How will you report it?
Specimen type, ma'am, liquid-based cytology. Specimen adequacy, ma'am, adequate for evaluation. Then endocervical cells.
Now it doesn't matter if you report presence or absence of endocervical glandular component. Then epithelial abnormality, squamous.
Yes, ma'am. Squamous, ma'am. Squamous cell carcinoma, ma'am.
That's right. And you have to mention that tumor diathesis is C.
Yes.
That is essential. And advised biopsy that
Biopsy.
Yeah. So now we have dealt with the squamous abnormalities. Glandular by itself is a very big and different chapter. Now, how does WHO classify recently to 2020 classification for CA cervix?
HPV dependent and HPV independent.
HPV independent and the NOS type. So we'll just try to conclude with some quality indicators when you're running a laboratory, cytology laboratory, how you should do the quality assurance. First thing, you have to review if there are epithelial abnormalities, you must review, get your slides reviewed by a second cytotechnologist or a cytopathologist that gives a proper control over the interpretation. You should not have over or under interpretation of lesions. Keep on calculating at regular time intervals the ratio of ASC-US to SIL, and it should not cross 2 to 3 is to 1. We are talking about this one. Here. Then you have to continuously correlate ASC-US cases with high-risk HPV positivity rates. If it has been advised, what is the result of that? Whether it was, how many of them were positive? How many ASC-US cases will be positive for high-risk HPV? Almost 40% to 50% will be positive. And correlation of ASC-US cases with the results of colposcopically directed biopsy. This must be done in your setup so that you get the confidence and you continuously have correct correlation and interpretation of both cytology and the biopsy material. And now coming to this important gray zone lesions, it's very important. Of all the cases, the simply atypical squamous cells, 80 to 90% are ASC-US, around 10% are ASC-H, and the ratio I have already told you. ASC-US occurs in more mature cells or mature metaplastic cells, and this occurs in immature metaplastic cells. And you have 90 to 94%, I've already told you, they are of the ASC are ASC-US, and 10% are of belonging to ASC-H. Then when you have a ASC-US, go for high-risk HPV testing if the woman is more than 25 years, and now they say if she's more than 30 years of age. And if it is she's less than 25 years of age, you just have to follow up the patient with smear after 6 months. But for ASC-H interpretations, you have to go in for colposcopy directly. Risk of HSIL in ASC-US is 18%. Risk of HSIL is around 45% when you are reporting ASC-H. And according to the ALT study, 50% high risk, 50% of the cases of ASC-US are high risk positive, and around 30 to 40% of the ASC-H are high risk HPV positive. Follow-up for under 25 is 6 to 12 months. And if colposcopy and here you have to go in for colposcopy, and if colposcopy and biopsy is negative, and that does happen a number of times, go for high-risk HPV test at 12 months. You do that, but you do it at a later stage. Okay. Any questions you have?
No more questions, ma'am.
Okay. I hope you could benefit, or it was too much of information for you.
No, ma'am, it was very, very beneficial. It was very helpful.
And Janvi, Shelly, what do you have to say?
It is very basic actually, includes all basic aspect of liquid-based cytology as well as conventional. You have included both the things very concisely in each and every case.
Yeah,
it is very nice, ma'am.
As we are using more and more of liquid-based cytology, we are still not out of conventional smears. So, and there are differences in the morphology. So, on large scale screening is going on mostly with conventional smears.
Conventional.
LPC is costly for institutes and for a higher class of people. And even HPV DNA testing is for a different category of population, affording category of population. So we have to still stick to the conventional smear, and that is what I'm doing, screening generally with conventional smears.
Thank you, Dr. Kamal, very much. It was a marathon session. I do not remember when we had 3 hours, and there are still 85 people. They don't want to leave you. But I really appreciate you were not well last week, and you managed to come back and come back with so much of force and power. Thank you so much, Dr. Kamal. And
my pleasure. My pleasure. I wish I could have taken lesser number of. I thought we would be able to handle it.
No, but I think it went very well. We need you again for maybe some other session. You decide whichever way you want to have 3, 4, 5 cases, and do another seminar. I'll come back to you.
We have not touched the glandular lesions at all.
No, we'll come back to you. I'll come back to you. I think I thank Shanaz, Chinmay, Shilpa and other students who are still there, and I kept you all away from food and water. I do not know. You didn't have even water, Dr. Kamal, in between. So thank
Yeah,
you very
I forgot totally. See, I was getting calls from home, but I couldn't.
No, yeah. I think I'll hand it over. There may be a couple of questions, but I would request the students, if you have anybody has questions, you can mail madam. It's already almost 10 now. We don't want to delay people here. But thank you very much, Dr. Kamal. I'll hand it over again to my moderators if they have anything to say for the next speaker. I'll share the link in next 1 hour. We will have it tomorrow. We have a talk on fixation artifacts in histopathology by Dr. Parveen Mahajan here. He's a professor. He's a consultant pathologist at SL Raheja Hospital.